use the general population to estimate bleeding risks. And for this was a RUNX1 haploinsufficiency platelet function disorder. We got very similar data to what we got for common platelet function disorders. Next slide. Next slide. So you can estimate bleeding risk for the more common and the unique families that you see. And, you know, in having discussions with anesthesia about neuroaxial anesthesia in a woman with a common platelet function disorder, as soon as I mentioned, you know, we've looked at these women and they've got a 17-fold higher likelihood of bleeding with childbirth and miscarriage, then they understood that this was a patient with significant bleeding risks, and that helped to make people feel more comfortable about proposed obstetrical management of pain control. Next slide. So I'm going to try and cover this quickly. I was involved in an initiative to work on improving life experiences for patients with rare bleeding disorders. This was initiated by 2 organizations in the United States that are pretty dedicated to supporting patients with bleeding problems. And the goal was to identify priorities of people with these diseases and to distill thoughts from experts on what we could potentially do to transform the experiences of people with these disorders. Next slide. So we had everything from affected patients to people from the Food and Drug Administrations, researchers, clinicians, a big team of individuals involved in this, which made for a really interesting collective group. Next slide. And so some of the things that we wanted to tackle were thinking about basic translational research questions about disease mechanisms and diagnosis and investigating therapeutics, to thinking about clinical trials that would be best for trying to improve the evidence on how to treat bleeding disorders. Next slide. Next slide. So some of the challenges that people discussed: if it's a rare problem, it's harder to get participants. Diagnostic challenge limits the ability to find cases. Very few centers have the skills and resources to conduct studies. And the longitudinal natural history often requires that you undertake such efforts as a multi-center international study. Next slide. The other thing that came up, and I'm not sure we came up with a way to solve it, is the issues of return on investments. Trying to get companies interested in diagnostics or therapies for rare disorders is a challenge, and it often doesn't meet their company thresholds. Next slide. So in terms of addressing gaps, I think our group had a lot of thoughts on ways that we could try to improve, and a lot of it involves us listening and carefully gathering data on patients about the problems that they experience over their lifespan, with increasing acknowledgement that things can change as they age. And to investigate patient-reported outcome measures might be important for understanding the true impact of a disorder, and asking questions about therapies and defining the need for novel therapies based on the person's bleeding history and what happens over their lifetime. Next slide. So the goal was to identify the research that could best improve people's lives with rare disorders, to create a national network of specialists to help doctors reach a diagnosis faster. And the idea was also to create a centralized laboratory specializing in ultra-rare bleeding disorders to improve diagnosis and do research. And I would say this create happens in a lot of countries, and from the dialogue I've had with even with people today, It sounds like you're working on initiatives to do this in your country as well. Next slide. So addressing treatment needs, we really need to understand the disorder to come up with best plans for treatment and develop pathways to treatment options to help affected patients, and studying new treatments and all the challenges it takes. It's I think not an easy task for many of the bleeding disorders that we see. Next slide. So I want to end with some patient perspectives as an inspiration. So this was a person with Quebec platelet disorder who, before he passed away, commented on what it meant to have had their disease researched and people to have learned about what they were experiencing and to come up with an idea of what was causing their problems, and then to actually find the cause and develop a test. And he said he used to be so worried if he had to have an operation or a tooth pulled, the bleeding was pretty horrible. Now there is a test, I know what I have, if my children have it, and why it causes bleeding. And he said, so I take my tranexamic acid when I need an operation and I am normal, which is an incredible thing for a patient to report. Next slide. So I just want to end by thanking people who helped in the journey that we've taken over the years in researching some of these bleeding disorders. There's fascinating conditions, and I can't thank the patients who've participated in these studies enough for all of what they've done to contribute to our successes. Thank you.
Thank you so much, Dr. Catherine. And more importantly, thank you for taking out the time for coming here and enlightening us on such an important topic. And we do not want your kind gesture to go unnoticed. I would like to request Dr. Salman Adil and Dr. Bushra to please present the shield to Dr. Catherine. Gulshan? From 2013 to 2014. She's also been a former chairperson for the Department of Pathology at King Edward Medical College and professor of hematology at CMH Lahore Medical College. As a mentor of her caliber, she has supervised more than 20 FCPS candidates and has given her time extensively in workshops and seminars. She will be joining us online today. Lastly, the moderator for this session is a doctor who has established her competencies for everyone to benefit from. Dr. Shabneez Hussain is the head of Department of Blood Transfusion Services at Indus Hospital and Health Network. Her subspecialty focus is transfusion medicine, hemoglobinopathies, and congenital bleeding disorders. With 16 publications, 18 papers, and a grant from the University of California, San Diego under her belt, she is an integral member of the hematological community. Dr. Shabneez, the floor is yours.
Thank you so much, Dr. Sabah, for a very kind introduction. I would like to invite Dr. Mohammed Nadeem to chair the, yes, we saw that. So, Dr. Nadeem to chair for the chair of the session, and I think Dr. Samina Naeem will join us online, right? Okay, so this is the beginning of hematology session 1, and it's benign hematological disorders and transfusion medicine. So before I begin, I would like to introduce Professor Dr. Suhaib Ahmed. Even before that, I would like to introduce the panelists for this session. The panelists is our Professor Dr. Samina Amanat, Professor Dr. Shahtaj Masood, Professor Wasim Iqbal, Dr. Aisha Imran, who is here, and Dr. Aisha Junaid, right? Right, so for our first talk, Major General Suhaib Ahmed, we cannot think about you without mentioning genetics in thalassemia in Pakistan. He was actually the game changer in this field, and I think he's very renowned in Pakistan for all the work that he has done in genetics. He is a PhD in molecular genetics in University College of London with over 32 years of experience in AFIP, Armed Forces Institute of Pathology, and his landmark research on extended family screening for thalassemia it's adopted in Pakistan as a countrywide method. So as I said, the game changer. And right now, currently he's a professor of hematology at Rifa International University, Islamabad, and he also heads the Genetic Resources Center in Rawalpindi, because one cannot leave his passion behind, so it has to continue at some forum. Right, and his talk will be on thalassemia-free Pakistan, how and when. Please, Dr. Suhaib.
Assalamu alaikum. First of all, I think I would like to thank the organizers, especially Dr. Bushra, for giving me this subject to talk about. Well, I think it's been nearly 3 decades that now we are into this business of prevention of thalassemia. We know that thalassemia is a preventable disease. I think there are no two opinions about that. But unfortunately, why things have not happened as we have expected them to be. This is what I'm going to talk about. And the second part would be that would it ever be possible to have a thalassemia-free Pakistan? Well, to begin with, let me tell you, we can't look at thalassemia in isolation. We have to look at the rest of Pakistan as well. तो याद रखिएगा ये थैलेसीमिया अकेला फेल नहीं हो रहा. I'm sorry अगर मैं कोई ऐसी मतलब वो स्ट्रेट अवे कोई ऐसी बात कर देता हूँ कई दफ़ा तो मेरा दिल से निकलती है वो बात. ठीक, I'm sorry. Coming back to the subject, well, without the pointer, I think I feel like being lost. अगर pointer दे दें तो I'll be comfortable. Thalassemia, preventable disease. It's a preventable disease. I think it's so simple, and the strategy is very simple, that you have to prevent marriage between two carriers, and secondly, if they're married, you offer them prenatal diagnosis. This is all about it. But how it can be done in this population of nearly 220 or maybe even more people in this country? Public awareness is number one, then carrier screening, genetic counseling, and prenatal diagnosis. So this is what I'm going to talk about, that what should be the strategy and what we have adopted, is it right or not? I think we have done a lot of work on awareness. I must commend that. There are a large number of people who have worked on it, and now nearly almost everyone knows about thalassemia. This is a big change. I think a very, very big change. At least in the 80s, when I started my training in hematology, I know that very few people knew about thalassemia. But now, if you ask even a layman, he would at least know the name. They may not know about the disease, but at least they know that thalassemia bhi kuch cheez hai. Well, for carrier screening, what has happened in the Mediterranean, I think this is a classic example. They adapted it. But it was not alone carrier screening. When they added prenatal diagnosis to that, then actually the dramatic result came. So we'll be talking about these one by one. Next slide, please. In the Mediterranean, you've seen that, and recently in Iran, this is what has happened. 2010, nearly no new births of thalassemia. They have achieved wonder. I think these are two classic examples. Now, Iran is a Muslim country. They started with carrier screening, but carrier screening alone was not successful. It was never successful. I think somewhere in the middle of maybe around 2005 or 2006, the parliament actually adopted a resolution where they actually legalized termination of pregnancy. And that was the game changer. When they noticed that the incidence of new births of thalassemia major, they came down drastically. So these are two classic examples, and we can actually follow those two, at least. Especially this Iranian example, I think, is very significant. It's a Muslim country, and it was introduction of prenatal diagnosis which actually changed the game. So this is I think, the bottom line. And I would like to emphasize that the screening, is it really important or not? And if at all it is important, that what should be the actually proper way of doing that? And secondly, prenatal diagnosis, if it is all that important, then how we can actually improve the network of provision of prenatal diagnosis to our patients. Next slide, please. This slide. ये स्लाइड का कंट्रोल यहाँ रख देना तो आई थिंक हाँ स्पीकर भी कंफर्टेबल होगा और ऑडियंस भी. आपको तो अपनी बातें और भी करनी होती. तो थैलेसीमिया इन पाकिस्तान, ये 1998, I think this book is from my PhD work. You can see that overall about 5% of the people in this country, they have thalassemia trait. And at that point in time, I calculated that about 5,000 new births of thalassemia children, they take place every year. And even today, people quote this figure. शायद लोगों को पता नहीं ये figure आई कहाँ से है, but this is somehow or the other quoted quite a lot. But we seldom realize that in these 20 years or maybe 25 years, the population of Pakistan has nearly doubled. So it is not exactly 5,000 children, new children. It's probably now 10,000 new children of thalassemia major who are being born. Well, I think this is one of the reasons that we are not witnessing any success of our prevention programs. We never take into account that the population is also increasing. Even if we have prevented the birth of new children of thalassemia, but it is the number which is actually increasing. It increases with the increasing population. So that you have to realize. Next slide. Well, our scenario is obviously fairly well known. We have a very large population. Well, people say that we have lack of resources, but let me tell you, we don't have lack of resources. It is the disorganized resources. मैं अक्सर कहता हूँ कि जिनके पास पैसे हैं, उनके पास अकल नहीं है, जिनके पास अकल है, उनके पास पैसे नहीं हैं. But this is the tragedy. Disorganized resources, I think, is the worst problem that we are facing. We have to channelize the resources. पैसे की कहीं से कमी नहीं है यहाँ, alhamdulillah. Variable level of development. If you go to the rural population, the level of development is totally different. If we go to something like Khan Hospital में चले जाएं, तो वो बिल्कुल, it's not Pakistan even. वो बिल्कुल ऐसे लगता है कि जैसे, I'm sorry, अगर आपको ये अच्छा लगे या बुरा लगे, but I think it's a compliment. आपका बहुत ज़बरदस्त वो सेंटर है, लेकिन उसका लेवल ऑफ डेवलपमेंट प्रॉब्ली वो नहीं है बट यू हैव इन स्मॉलर सिटीज़ और इवन टाउन्स, या आप रूरल पॉपुलेशन में चले जाएं जहाँ पर पेशेंट्स हैं. द बल्क ऑफ द पेशेंट्स इन फैक्ट दे आर लिव इन दोज एरियाज वेयर द फैसिलिटीज आर नॉट रियली अवेलेबल, एंड पीपल रियली डोंट फील लाइक ट्रैवलिंग टू प्लेसेस विच आर रियली वेल डेवलप्ड बिकॉज इट्स logistically difficult, it's more expensive. So these are the unique problems, and literacy, of course, is a very big problem. Literacy से ज़्यादा, I think it is the show. It's not just the education that you get. It's the awareness in your mind that actually helps you in understanding what's wrong or what's not wrong. And of course there is no end to the list. We don't have enough time to talk about those problems, but we'll be focusing. Kindly, may I have the next slide, please? Thank you. Now let's see the challenges. Awareness, we have talked about it. It's really commendable that people know about it. Now, I think the first thing that we lack is a thalassemia registry. We do not know the exact number of patients with thalassemia. And more than that, I think when you talk about prevention, we need to know from where we have started. What is the birth incidence today? Or maybe 30 years ago, what was the birth incidence of thalassemia major? Only then we can know that whether we are heading forward or just stationary or even going down. So we have to have the start point at some point in time. Thalassemia registry has been created by a Punjab Thalassemia Prevention Program, but unfortunately, and this is another unfortunate thing, that most of the time thalassemia is being handled by people who are not hematologists. Whether you take NGOs or you take prevention programs or whatever. Generally, you don't have उनके पास technical experts नहीं हैं. They don't have hematologists amongst them who should actually advise them that what to do and what should not be done. Registry is a must. We must know that how many children are born each year with thalassemia major. I think it's not very difficult. You simply have to count the number of children coming to these thalassemia centers. We are fortunate that we have large number of NGOs who are working with thalassemia, and most of the patients, they come to these NGOs. And it's not difficult to register new cases of thalassemia. Or it's only just a matter of taking some interest in it. And people should know that this is important. Maybe sometimes I wonder that these people, they deliberately don't establish a registry. Otherwise, तो पता लग जाएगी ना आप किस तरफ जा रहे हैं. तो this may be one of the reasons. अच्छा ये इसके ऊपर नहीं नजर आता है स्क्रीन पे. This is another problem. चैलेंज है. आपको पॉइंटर का वो टिप नजर आ रहा है? आता है. अच्छा ठीक है, मुझे नहीं नजर आ रहा. तो कैरियर स्क्रीनिंग, अच्छा ठीक है, इट्स ओके. नहीं मुझे अब स्क्रीन नजर आ रही है. ये पॉइंटर का ये जो लाइट है ना, ये इस पे तो नजर आती है ना, ऐसे ही आती है तो डिम हो जाती है. Carrier screening is important, लेकिन let me tell you the example of Mediterranean program. It started somewhere in 70s when it became possible to identify carriers of thalassemia. They started the program and they offered screening services to their population, but there was no decline in the birth rate of new children with thalassemia. Somehow or the other, this is what happened. Somewhere around 1980, prenatal diagnosis came in. And that was the point when actually the birth incidence of thalassemia major, they drastically came down. And the same thing happened in Iran. So it is not the carrier screening alone. Remember that. It may be important, but there are several other issues related to this carrier screening that I'll be talking about in a later slide. So prenatal diagnosis is a must. And I think we have laid too much emphasis on carrier screening, and most of the time people who in fact are talking about thalassemia, they say that there should be a law in this country that you should actually enforce carrier screening, and this column should actually be included in the Nikah-nama, and at the time of marriage you should ensure that one of the partners at least doesn't have thalassemia trait. Well, this is not practical at all. Prenatal diagnosis is the most important part of prevention. If thalassemia-free Pakistan has to come someday, then it will be through prenatal diagnosis, rest assured. Another important issue is consanguineous marriage. We can't really, you can't tell people to stop marrying cousins because this is a part of our culture for several hundred years. It's been going on. There's no point in actually advocating that you should prevent cousin marriages. There is a possibility that you can offer carrier screening within the family and cousins get married without having thalassemia carrier screening. I think it may be risky, but if you offer carrier screening, then you can have consanguineous marriages and at the same time you can avoid the birth of children with thalassemia major. Next slide, please. Well, you must have a starting point. Punjab Thalassemia Prevention Program, unfortunately, they have started a registry. The registry program that they have built, I fail to understand why they are documenting the patients. And there are so many different aspects of those patients which are being recorded in that registry that it has actually become a burden for the people who are entering that data. वो बगैर सोचे समझे वो एक रजिस्ट्री बना दी गई है जिसमें उस बच्चे की ये कि वो स्मोकिंग तो नहीं करता, कहीं वो भी लिख दिया उसमें, और पता नहीं किस किस तरह की ऊट पटांग चीज़ें जो हैं उसमें डाल दी गई हैं. तो बेसिकली व्हाट यू नीड फ्रॉम द प्रिवेंशन पॉइंट ऑफ व्यू इज दैट यू नीड टू डॉक्यूमेंट पेशेंट्स हु आर न्यू, who are diagnosed for the first time, and they are actually, whenever they come to any treatment center, they should be documented. But it's as simple as that. You should have this figure. At least every year we should be able to evaluate the progress of your program. Next slide. I've told you that the experience in the Mediterranean and Iran, they have proven that carrier screening alone is not enough. The Pakistani experience, इसमें I'll tell you, तीन मैं आपको छोटे-छोटे से वाक़यात सुनाऊंगा. I'm sorry, most of the time these incidences they happen in Urdu or the native language, so I have to narrate it in the same language. Once, while I was doing my PhD work, I worked on extended family screening, and there was a doctor who was my colleague. He was a surgeon, our medical corps. He came to me with a child whom we diagnosed as thalassemia, and I offered him that I'll do extended family screening in your family. He had a fairly large family, Faisalabad somewhere. So we started that screening. We screened about 200 people in this family. It was a very large family. And ultimately there were several people who had thalassemia trait, and we told them that this is what it is. And within about a couple of months, this doctor once came to me. सर ये आपने मुझे किस मुसीबत में डाल दिया? What has happened? और हमारे ख़ानदान में तो शादियाँ होनी बंद हो गई हैं. मैंने कहा why? But people are so scared. So this is what it is. Okay, in one particular family, you have actually loaded them with information about this. वो कहता है मेरा एक भाई है, उसकी कैरियर है वो, उसका हमने रिश्ता किया जब, तो वहाँ बताया कि जी लड़के को थैलासीमिया माइनर है, तो आप लड़की का ज़रा टेस्ट करवाएंगे. तो ये क्या अभी, वो तो मंगनी टूट गई उसकी. उसके बाद second time the same thing happened. So you have to keep in mind that this is what can actually happen during carrier screening. The second incident, my teacher, late Jana Salim, he was executive director of NIH, and one day he said the Minister of Health at that time, his blood sample came for testing. And when he looked at the report, it was clearly indicating that he had thalassemia trait. So he called him back, कि सर आपके ब्लड में थैलासीमिया लग रहा है हमें. तो you know what was his reply? डॉक्टर साहब अपने काम से काम रखें, ये आपका काम नहीं है. ठीक है. So this is the mentality and mindset, right? तीसरा वाक़या बिल्कुल recent है. A few students from NUMS, they came to me that we want to do research on a genetic disease. So I do prenatal diagnosis for different diseases. There was a very rare genetic disorder for which I had recently done prenatal diagnosis, and the variant in that particular family could be detected by a very simple PCR test. So I told them that मेरे पास ये patient आया था, इसको मैं कहता हूँ कि अपनी पूरी family की screening कराए. तो ये बड़ा simple होगा, और it will be a very exciting study. You can even publish it internationally, बड़ी अच्छी publication बन जाएगी. मैं भी उससे बात करता हूँ. I called him. वो आगे से जो दिन रात मेरा दिमाग खाता था कि जी मेरा रिजल्ट कंप्लीट हुआ या नहीं हुआ, उसको मैंने कहा कि वी हैव एन ऑफर, वी कैन टेस्ट योर एंटायर फैमिली, वुड यू बी विलिंग टू पार्टिसिपेट इन इट. तो वो कहता है सर मैं आपको बताता हूँ, अभी बताता हूँ, पेशावर से. तो उसके बाद अभी तक उसकी कॉल वापस नहीं आई. सो रिमेंबर, कैरियर स्क्रीनिंग बड़ी अच्छी चीज़ हो सकती है, लेकिन नॉट फॉर दिस कंट्री. रिमेंबर दिस, प्लीज़ डोंट ले टू मच एम्फेसिस ऑन दिस. ये नहीं कामयाब होगी, मैं आपको बता रहा हूँ. दिस इज़ व्हाट माय एक्सपीरियंस इज, दिस इज़ व्हाट अदर पीपल्स हैव एक्सपीरियंस. और मैंने आपको 2-3 एग्जांपल्स दिए हैं, बहुत सारी एग्जांपल्स हैं, बट आई कांट रियली नरेट एवरी एग्जांपल. नेक्स्ट स्लाइड प्लीज. हाउ मच आगे, और बस ठीक है, आगे चलती जाइए. अगर इफ एट ऑल वी हैव टू डू कैरियर स्क्रीनिंग, इट शुड बी थ्रू एक्सटेंडेड फैमिली स्क्रीनिंग. वो आपको पहले आई थिंक इट हैज़ बीन टोल्ड. लो कॉस्ट कैरियर स्क्रीनिंग मेथड, ये मेथड बहुत ही सिंपल है, एक्सट्रीमली सिंपल मेथड. इतना सिंपल है कि इट्स रिडिकुलस टू बिलीव कि आप यू कैन डू स्क्रीनिंग इन लेस देन, अभी तो थोड़े से पैसे ज़्यादा लगते हैं, ज़्यादा इस पर, प्रॉब्ली लेस देन 100 रुपीज़ यू कैन स्क्रीन अ पर्सन विद सच ए चीप मेथड. इट्स पॉसिबल, प्रैक्टिकल. इक्विपमेंट बनाया, सब कुछ किया, बट यू नो व्हाट पीपल आर्ग्यूड कि जी ये मैनुअल तरीका है, टेक्नीशियन को बड़ी मुश्किल होती है इसमें. फॉर हेवन सेक, यू स्पेंड 1000 रुपीज़ ऑन वन टेस्ट. वही पैसे आप अगर मैन पावर के ऊपर लगा दें, उनको पेज देनी शुरू कर दें, उनको जॉब अपॉर्चुनिटीज़ मिल जाएंगी. यू विल हैव एक्सटेंसिवली अवेलेबल कैरियर स्क्रीनिंग. सो आई थिंक दीज मेथड्स शुड बी, इसके ऊपर भी कॉन्सेंट्रेट करना चाहिए. फिर वही बात आती है जी कि पैसे तो हमारे पास बहुत हैं, वी हैव लॉट ऑफ मनी टू वेस्ट, बट उसको सही जगह पे नहीं लगाते हम. नेक्स्ट स्लाइड. मेरी टॉक ज़रा जिटरी होती है, प्लीज़ बेयर विद मी. इसमें हकीकत होती है इसके पीछे कहीं ना कहीं छुपी हुई. प्रीनेटल डायग्नोसिस वी स्टार्टेड इन 1994 एंड अगर आप ये ग्राफ देखें तो इट्स गोइंग अप लाइक ए रॉकेट. ठीक है ना, अभी हम 2500 प्रीनेटल डायग्नोसिस एवरी ईयर करते हैं, बट दिस इज नथिंग, लेट मी टेल यू. नेक्स्ट स्लाइड दिखाएं सर, स्लाइड दिखा दें मुझे प्लीज. अच्छा ये आपने दिया, आई एम सॉरी. चलिए, हम जो प्रीनेटल डायग्नोसिस करते हैं इतना शोर मचाया हुआ है. This is not even 20% of the total. 10%, even less than 10%. I think still there are 90% of the couples who are at risk every year who need prenatal diagnosis. They must be given or offered prenatal diagnosis. Please remember that. You need to enlarge this horizon. इधर है. Unfortunately, ये जो आपको मैंने 10% बताए हैं फिगर, nearly half of these patients, they are the ones who have already had prenatal diagnosis. So we are not actually recruiting new patients. The new patients are not even 5% of the total. So that I think is very, very significant. अगर यही वो कॉर्नरस्टोन है जिससे हमने प्रिवेंशन करनी है, तो यू नीड टू एक्सपैंड दिस नेटवर्क. कैसे किया जाएगा ये, दिस आई थिंक इज चैलेंजिंग. इसको क्या कर सकते हैं हम इसके लिए? These are some of the reasons why people don't accept prenatal diagnosis. Number one, I think cost is very important. But Punjab Thalassemia Prevention Program, they're offering free of cost prenatal diagnosis. Even then, people are not coming to avail this facility. So this, I think, is worrisome. It's not just the cost. It's an attitude, perhaps. As a nation, आपको पता है जब तक सर पे आके फटता नहीं है बम, तो we are not really worried about it. उस वक्त जाके फिर फैसला करते हैं अब क्या किया जाए इसके लिए. रिलीजियस बिलीव कोई मसला नहीं है. देयर इज नो प्रॉब्लम एट ऑल. Information should be available to people. I think awareness. Still, there are doctors who do not know about prenatal diagnosis. Still, there are patients of thalassemia who do not know about prenatal diagnosis. I think someone needs to do something about it. This is a big challenge that you need to make people aware that this facility is available. It's possible to have prenatal diagnosis. It's such a simple test. And if you talk about the cost, this is not even expensive. 10,000 rupees make prenatal diagnosis hota hai, and one family has to get that prenatal diagnosis maybe 3 or 4 times in his lifetime. तो उसके लिए 30-40 हज़ार रुपये तो कुछ भी नहीं है. We need to increase the number of trained obstetricians, not just obstetricians. I personally believe even ये जो midwives हैं ना, वो भी CVS कर सकती हैं अगर आपको ट्रेन करना हो तो. I have मतलब I think it's possible. इसमें ज़रूरी नहीं है कि बिल्कुल डॉक्टर हो. अब तो डॉक्टर वैसे भी इतने ज़्यादा हो गए हैं हमारे पास माशाल्लाह, और ख़वातीन तो कोई शुमार ही नहीं है डॉक्टर्स का. तो we need to train them all. और अलहमदिल्ला मुझे being a hematologist, I started doing CVSs just because they were not competent. लोग नहीं मुझे नज़र आते थे अपने दाएं बाएं. तो उसके बाद मैंने 20 के करीब तो ट्रेन किए हैं अलहमदिल्ला. आपके आगा खान अस्पताल में 2 कंसल्टेंट हैं, वो मुझसे ट्रेनिंग लेके गई हैं. अभी बिल्कुल रिसेंटली एक और ने ली है. कराची में 1-2 और भी हैं, उनको भी मैंने ट्रेन किया था. आपके फातमीद में भी. हाँ, तो वी स्टार्टेड दिस. वहाँ तो आपको मैंने पूरी लैब बना के दी थी एक. हाँ हाँ हाँ, बदीन में है. बदीन में यस, डॉक्टर वो हैं, उनका नाम मुझे हमेशा ही भूल जाता है. अरुण के साथ नहीं, वो उनके खातून है. उन्होंने मेरे पास 1 महीना किया था. पेशावर में 3-4 हैं इनको. तो अल्हम्दुलिल्लाह ये तो नेटवर्क बहरहाल है. पंजाब थैलेसीमिया प्रोग्राम भी बड़ा अच्छा इस पर काम कर रहा है, बट आई थिंक बहुत ज़्यादा ज़रूरत है इसमें. आप हेमाटोलॉजिस्ट जो हैं इनको भी CVS करने की ट्रेनिंग होनी चाहिए अगर चाहें तो. अगर मैं बीइंग मेल कर सकता हूँ ये काम, तो आप लोग तो बड़े आराम से कर सकते हैं. कंसैंगुइनस मैरिज में आई थिंक ये प्रोफेसर मॉडल है, ये उसकी डायग्राम है, मैंने वहाँ से ली थी उससे विद हर परमिशन. मेरे पास जब भी पेशेंट्स आते हैं, दे वुड द फर्स्ट थिंग दैट दे टेल मी इज दैट They come with a child having genetic disease. तो वो बजाय अपने बच्चे की बात करने के सबसे पहला वो जो मुझे बात बताते हैं, हम कज़न हैं जी, we are cousins, as if they have committed a crime. People have hammered this information onto their minds that your child is sick because you're cousin. Yeah, this I think attitude needs to be repaired. This is very bad. इसमें क्या आप उनको सजेस्ट करते हैं कि बस ख़त्म करें अब इसको, कोई और नई शादी कर लें? ये तो नहीं ऐसे, ये solution नहीं है. Now it is possible to do career screening within that family, and you can have consanguineous marriage and yet avoid thalassemia. Final slide, बहुत ज़्यादा टाइम नहीं लिया मैंने, I hope. आपने कहा था जी कि when will we have thalassemia free Pakistan? I think इसमें एक फिगर है जो कुछ चीज़ें हैं जो हमारे कंट्रोल में हैं. There are certain things which we can't control. The one that we cannot control is infant mortality. इस वक्त infant mortality जो है ना बहुत हाई है, probably somewhere around 60 या 65 है, कुछ ऐसे है, and it is mostly because of infectious diseases. When these infectious diseases will come under control and the mortality of infants would fall to somewhere around 40, then the mortality would be mostly not because of infectious disease, it will be because of something else, and that something else most likely is going to be genetic disorders. So a time will come in when you will have most of the children dying because of genetic disorder. उस वक्त हमें समझ आएगी कि ये तो अब कुछ करना पड़ेगा इसके लिए. तो now is the time that you start planning. तो थैलासीमिया फ्री पाकिस्तान की बात उस वक्त बहुत जोर पकड़ जाएगी. अभी शायद हमें नहीं समझ आ रही पूरी तरह, but with the passage of time, people will start realizing. Secondly, we need to realize that the burden is also increasing because of the increasing population. अब ये कब होगा जाके ये पूरा ख्वाब? कभी तो होगा. Not probably, मेरी ज़िंदगी में तो शायद कभी भी नहीं होगा, लेकिन यंगस्टर्स आप बैठे हैं यहाँ पर, प्रॉब्ली हो सकता है आपके लाइफ टाइम में यू कुड एक्चुअली, कोई आए आगे कुछ चैलेंज को देखे तो सही. आपके हेमाटोलॉजिस्ट, अब अल्हम्दुलिल्लाह वो क्लिनिकल हेमाटोलॉजी का शोशा आपने अंदर छोड़ लिया, तो नाउ हेमाटोलॉजिस्ट आर एक्चुअली डाइवर्टेड टुवर्ड्स दैट. ये फितना मैंने स्टार्ट किया था, बट नहीं, मैं ये नहीं कह रहा हूँ कि वो बुरी चीज़ है, बहुत अच्छी चीज़ है, बट आई थिंक व्हाट वी नीड टू रियलाइज इज दैट वी नीड टू ओन थैलासीमिया. थैलासीमिया को आप हेमाटोलॉजिस्ट कम्युनिटी है, इसको लें. मैं कब से बैठा हुआ लोगों को कह रहा हूँ कि आइए प्लीज़, मुझे अपना कोई जानशीन चाहिए, मुझे कोई तो हो बंदा जो मेरे साथ बैठ के कुछ देर चीज़ों को सीख ले और आगे चलाए इसको. लेकिन अनफॉर्चुनेटली ये सिलसिला कोई मुझे बड़ा स्ट्रेंथ पकड़ता हुआ नहीं नज़र आता. लेकिन बहरहाल वी नीड पीपल, वी नीड यंगस्टर्स हु शुड टेक ओवर. Unfortunately, जो पंजाब थैलासीमिया प्रिवेंशन प्रोग्राम है, let me be very vocal and loud and clear, वो it's being headed by a person who is not even a doctor, which is very very unfortunate. Which I think डॉक्टर यास्मीन को मैं तो उनके मुंह पे भी कह देता हूँ कि आपने ये ज़्यादती की है. और now that was the time जब PTI की अपनी गवर्नमेंट थी, she was in fact she still is health minister, और उसमें भी अगर थैलासीमिया के लिए हम वो नहीं कर सके तो फिर कौन करेगा और कब होगा ये? नहीं अपना है या जो भी है, बट ही शुड बी एटलीस्ट डॉक्टर तो होना चाहिए ना उसको. बहरहाल चलें उसको छोड़ें. तो थैलासीमिया फ्री पाकिस्तान इंशाल्लाह बन जाएगा हमारा, लेकिन हमारी ज़िंदगियों में तो नहीं बनेगा, लेकिन कभी ना कभी बनेगा. मेरा एक दोस्त है फेसबुक पे, ही हेड्स अ NGO, वो अक्सर ही अपनी उसने पोस्ट लगाई होती हैं, या अल्लाह थैलासीमिया से पाक कर दे मेरे मुल्क को, लेकिन वो खुद कुछ नहीं करता है. थैंक यू. At least the organ.
Thank you so much, Dr. Sway, for a very controversial talk. But I think if we take out some take-home message, no. But if you take out some take-home message, looking on the brighter side, you did make progress in the country. And if we talk about genetic screening in this country in thalassemia, it's you we think about first. And I think this is the right platform to actually talk about it, that he is looking for a success. He is actually going on to succession planning. So if any of the hematologists is interested, definitely, General Suhaib, I think it's high time somebody should take this forward in this country. So with this, we'll move on to our next speaker, Professor Dr. Nisar Ahmed. And Dr. Nisar, I think in pediatric hematology, whenever we think about pediatric hematology, Dr. Nisar is the first thing that comes to our mind. Another thing is the numerous residents which are coming off from in hematology. Again, in Punjab as well as going on to other parts of the country, Dr. Nassar again. So Dr. Nassar is, he joined Children's Hospital in the capacity of assistant professor in 1995. And there he stayed and transformed the setup into a large complex for hematology services. Dr. Nassar has over 30 publications under his name, and his leadership qualities have been well defined. He has also been the past president of PSH, and currently he is the professor of hematology and oncology and transfusion medicine, as well as bone marrow transplant unit at Children's Hospital and Institute of Child Health, Lahore. He will talk about neonatal thrombocytopenia, diagnostic dilemma. Thank you, Dr. Nassar.
Bismillahirrahmanirrahim. Assalamu alaikum. First of all, my thanks to the organizer giving me the opportunity to share this topic. And special thanks to Professor Bushra Moise, because she has selected this topic, challenging in neonatal thrombocytopenia. Because it's a challenge, because in the last 30 years, we haven't discussed even a single meeting about neonatal thrombocytopenia. So this is going to be first time we are going to discuss neonatal thrombocytopenia in our scientific meeting. So I will discuss what are the challenges of this. First slide. यार बातें कम करो. चले. So we will discuss what are the challenges in our setup, especially when you are working in a tertiary care hospital or in a non-teaching hospitals, because as the General Saab said, working in a tertiary hospital is a different game, ball game, and when you are working in DHQ, THQ is a different game. So just before we start the neonatal thrombocytopenia, as we know, the thrombocytopenia, low platelet count, is the most common consult in the hematology. After anemia, I think this is the most important consultation when you ask about the hospitalized patient or in the OPD. And because of the dengue epidemic, these platelets have more important amount consultation as compared to anemia. यहाँ लोग आते हैं पंजाब में, वो कहते हैं मेरी प्लेटां घट गई हैं जी, मेरी प्लेटां ठीक करो. So patient have been sensitized and more awareness about the thrombocytopenia rather than anemia. Anemia जो हमारे मुल्क में बहुत common है, it's very common in our country. But because of the dengue, we have more awareness about the platelets. और patient ज़रा platelets की फिक्र करता है, फिर anemia की फिक्र नहीं करता. And again, another because of the importance of these platelets is political platelets by the our country prime minister. उसकी वजह से लोग और भी ज़्यादा पॉपुलर हो गई प्लेटलेट्स. Now everybody knows कि वो बीमारी जो नवाशी हुई मेनमी हो गई, ठीक करो. So that's why this the thrombocytopenia in clinical practice or even in lab practice is very important. वो दशक आखिर at the end of this slide. She says she's not neonate, she's geriatric thrombocytopenia. So when it comes to the incidence, because basically the thrombocytopenia, absolute thrombocytopenia, by definition is when you have the platelet count less than 150, irrespective of gestation age, and it has been estimated 1 to 5% of all neonates, they have the thrombocytopenia. And when you have the critical patients or the patient admitted in your ICU or the NICU, which is in the neonatal ICU, we have 50% of all patients, up to 50% patients, they are suffering from thrombocytopenia. So the main challenges in the management of hospital patient with thrombocytopenia to identify the underlying cause. That is the most important part, and recognize when urgent intervention is required. This is again an important point. Thrombocytopenia diagnosis is important, but at the same time, you have to see what is the importance of underlying disease. It's an emergency or it's just a thrombocytopenia. So it's the responsibility of the hematologist or pediatric hematologist to identify the underlying cause and intervention required in those cases. As you know, this is the traditional approach to the thrombocytopenia according to etiology is decreased platelet production, increased platelet destruction, or platelet suppression. This is a normal hematologist opinion or the approach toward diagnosis. But we should know the many disorders of thrombocytopenia, they have more than one cause. This is a very important aspect when you are treating with the neonatal thrombocytopenia. It's not one particular cause which is affecting. For example, in ITP, we know platelet destruction, platelet underproduction is the most important cause of ITP. Similar, in critical ill patients, especially in neonatal thrombocytopenia, you have more than one or more than two causes at the same time. So you have to identify all those causes when you are doing the management of these cases. I think this is again a gold standard whenever you have a diagnosis of an in medicine. We have to, through this history, especially the medical history, family history, physical examination, and appropriate body investigation. Before we took the neonatal thrombocytopenia, I think some of the practical points when you are dealing with any type of thrombocytopenia you must have. This is the most important part, especially in neonatal thrombocytopenia, that is exclude the thrombocytopenic emergencies. This is the most important part because you have diagnosed a thrombocytopenia, low platelet count, but most important part is which patient needs emergency identification and management. And these are the few list on diagnosis, that is any patient with primary ITP bleeding, drug-induced, HIT, TTP, DIC, these are the conditions which needs urgent recognition and management of these cases. Similar, this is as a lab hematologist, the most important part is when you are examining any patient with thrombocytopenia, you have to focus on these points. Especially, most important is you first of all you have to rule out this pseudothrombocytopenia. Similar, schistocyte, the presence of TTP or DIC again is showing this thrombocytopenia is an emergency. You have to act very quickly to diagnose and manage these cases. Similar, giant platelets in ITP, in hereditary thrombocytopenia, small, all these points help in the diagnosis, at the same time help in the management of the thrombocytopenias. Similar, you have to assess whether you are dealing with the severe, mild, moderate thrombocytopenia according to the platelet count. And again, you know, all thrombocytopenias or neonatal thrombocytopenia are not associated with bleeding. Some of the thrombocytopenias, they are associated with thrombosis. So you have to keep an eye whether you are dealing with the bleeding disorder or thrombotic disorders. For example, in the HIT, if you know, in the critical patient, you are doing giving the heparins, and patient can have it. Similar, in TTP, I think in the TTP, when we discuss the etiology of or the causes of thrombocytopenia, when we discuss this one. Now we start the actual how to investigate a case of neonatal thrombocytopenia. A neonatal thrombocytopenia is classified according to the age of onset and clinical status. Either early onset, late onset, or variable onset. For example, early onset means when you have a thrombocytopenia within first 72 hours. We call it the early onset, and the most important causes of this early onset is antenatal, fetal, or perinatal events. So all fetal events or perinatal events like chronic fetal hypoxia, the asphyxia, intrauterine growth restriction, maternal hypertension, autoimmune, maternal, intrauterine infection, congenital inherited, all these causes can cause thrombocytopenia in first 72 hours, which is known as the early onset thrombocytopenia. It's helped in the, not in the diagnosis, even in the management of the cases, what to do next for these cases. This is again a fetal and neonatal alloimmune thrombocytopenia, which is similar to, we have the hemolymph disease of fetus and newborn. But important point is, in hemolymph disease of newborn, we don't have the first pregnancy affected. But in case of fetal and neonatal alloimmune thrombocytopenia, the 50% cases are affected in the first pregnancy. And its incidence is 1 in 1,000 to 5,000 live births. And most important thing is, most of these disorders are due to human platelet antigen 1A. The rest of the causes are due to human platelet antigen 3A or the 5A. And why we want to diagnose this case? Because the intracranial hemorrhage, which is most important complication of this disease, happen in alloimmune neonatal thrombocytopenias. So that's why the cranial ultrasound or the CT scan or MRI of head is mandatory in cases of when you have the fetal and neonatal intracranial hemorrhage due to thrombocytopenias. This diagram shows how when you have fetal have the human platelet antigen positive, and the antibodies, these cross to the maternal, and Ig antibodies are produced, and these Ig antibodies are responsible for this fetal or neonatal alloimmune thrombocytopenia, which is resulting in the severe form, resulting in the intracranial hemorrhage. And treatment is again, you have to transfuse compatible platelets, or if platelets are not available, IVIG 1 gram for 1 to 3 days, or methylprednisolone. And main target is to maintain platelets in more than 30 in well babies, and more than 50 in breeding babies, and more than 1,000 platelets in the intracranial hemorrhage. And these platelets should be irradiated and washed with the platelets. This is recently a paper published in last week in the Blood, the Journal of American Society of Hematology. They have the mouse model in which they have produced the anti-HBA antibodies, and these have been transfused into the mouse, resulting in the clearance of positive HBA positive thrombocytes and resulting in the complete recovery. So this is going to be a very effective model for the further research. By this, you can have the passive transfer of antibodies, which remove your HBA positive thrombocytes and result in the prevention of this fetal and neonatal alloimmune thrombocytopenias. This is again a neonatal autoimmune thrombocytopenia. Basically, it's a secondary to the transplacental passage of maternal platelet autoantibodies due to ITP, to SLE, or due to any other autoimmune disease resulting in a thrombocytopenia. And in neonates, it can be resulting in neonatal Kawasaki disease, and again treatment IVIG, and again you can see you can have the 10% newborn with less than 50, 5% newborn with less than 20, but important thing is, as compared to alloimmune, intracranial hemorrhage is very rare. It's very rare. So again, monitoring of platelet count is required for first 5 days. Then comes the late onset. That is when you have thrombocytopenia after 72 hours. And most of the late onset thrombocytopenia is due to postnatal events. That is late onset sepsis, fungal infection, necrotizing colitis, maternal autoimmune disease can present, and drugs are the main culprit in the late onset thrombocytopenia. Genetic disorders, again, a very common cause of thrombocytopenia after 72 hours, and we have discussed Turner syndrome, trisomy 18, trisomy 21. You know the transient abnormal myelopoiesis, which is most important presentation in the neonatal age. Because of Down syndrome, you have low platelet count with the increased blast. Then inherited thrombocytopenia, we know inherited thrombocytopenia classified according to thrombocytopenia and size of the platelets. It can be normal size, normal thrombocytopenic purpura, micro thrombocytopenic purpura, or macro. So all these conditions are recognized after 72 hours. Large platelets we know in the Bernard-Solé syndrome, in the Geta mutation, GPS, all these disorders. And most of these disorders are managed by the IVIG, irradiated platelet transfusion, and adjunctive therapy, or very rarely with the hematopoietic stem cell transplant. And then third group, which is not early onset or late onset, we have the variable onset. It can present at any stage of, usually these are the combined disorders like DAC, thrombosis, especially renal arteriostenosis, late sepsis, metabolic disorders, and neonatal liver disease. And bacterial infection is again a very, very important cause of neonatal thrombocytopenia in our setup. And we know, again, you can see different causes. Sepsis is a systemic inflammatory response characterized by multifactorial. You have the enhanced peripheral clearance, direct toxic effects of toxin, DIC, and decreased platelet production in these disorders. Similarly, the DIC is again a very important. So many conditions can converge into the DIC, especially the sepsis, and especially necrotizing enterocolitis, liver dysfunction, all these. So what are the indications of platelet transfusion in neonatal thrombocytopenia? Transfusion of platelets concentrated is the only therapy available for many forms of neonatal thrombocytopenia, and this is the triggers. Well, in well babies where we have a platelet count less than 20, you need a platelet transfusion. In sick babies, platelet count 30 to 50, and these platelets should be RH compatible. Specific and irradiated platelets should be given to these patients. And this is just a pilot study we started last in the first week of November when we have this topic. And this is just data of the 2 weeks. And you can see the mostly patient age and sepsis is the most important cause. And if you see, we had 20 cases, male and female almost equal. And you can see more than 72 hours, less than 72 hours, we had 12 patients, and more than 72, 8, and placenta insufficiency 1, maternal autoimmune 2, perinatal infection, asphyxia 2. The rest of the cases were the sepsis. You know, the very high infant mortality rate and very high even the infant neonatal rate is because of the sepsis in our setup. If you go to the neonatology units, you will see almost 90% patients, they are labeled as a late or early onset sepsis. And most of the patients, they are getting the variety of antibiotics. They are receiving at least 4 to 5 antibiotics they are getting in our setup. So what is the role of hematologists in the neonatal thrombocytopenia? I think the most important is to determine the cause of thrombocytopenia, because your management will depend upon whether it's an emergency or not an emergency. So that will advise in the management of thrombocytopenia, and it's at the same time also help to estimate the risk of mother and fetus. And what are the challenges in our setup? because we have lack of training in neonatal hematology. Most of the hematology, they are not exposed to neonatal units. That's where they have no idea how to diagnose and how to manage these cases. And again, because this topic is less frequently discussed in our scientific meeting, and sampling issues again in neonatal problem. That's why we don't have the difficulty in access to mother for history. Neonate is a critical care having multiple etiology factors in neonatal thrombocytopenia. Again, most of the centers, they don't have the facilities to diagnose these cases. Thank you very much.
Thank you, Dr. Nassar, for a very enlightening talk. Right now, we are adjourning for a break and poster review. We'll start the session. We'll continue the session at 11:30. Thank you so much. Shields at the end of the session.
guide them for the prevention of these severe types of bleeding disorders in our community. The patients, our data have shown that patients who had the history of consanguinity had more symptoms as compared to those who had no history of consanguinity. The molecular studies helps us to definite the diagnosis of the rare bleeding disorders and facilitates us with the carrier identification in our patients. For the infusion of clotting factor concentrates, unfortunately in Pakistan we don't have the clotting factor concentrate so much. The luxury is not with us. Particularly in the rare bleeding disorders, we have to depend on the FFP transfusions or its byproducts. Sometimes through the World Federation of Hemophilia or through the other NGOs, we arrange the factor 10 concentrates, factor 1 and the factor 13 concentrates through the Hemophilia Welfare Society Karachi. But usually we treat our patients with the help of FFP. And I have kept my patients on the prophylaxis, especially with the GI bleed, especially with the intracranial bleed. They are kept on prophylaxis to prevent the future bleeds. And alhamdulillah, they are maintaining good quality of life if you properly counsel them and treat them accordingly, according to the factor levels, and maintain a good factor activity level. So more research is needed to diagnose basically the structure and the pathogen mutations in our population, because the data on the rare bleeding disorders is very much lacking, because in the western part of the world they don't have family marriages. In our part of the world, as we have more family marriages, so these data are generally generated from the population who have a culture of family marriages. Like you will see the rare bleeding disorder, more data from Iran, India, Pakistan, all the countries of those Eastern countries or Muslim countries where there is a culture of the population getting married to the family members. They don't like to go outside of the family. You cannot prevent that, but at least you can counsel them to improve the quality of life, especially the females, because the females are more sufferers as compared to males. So proper counseling is very much needed to diagnose them, to help them, and especially for the carrier detection. Thank you very much.
Thank you so
I'm
much.
happy to take any questions.
We'll take those questions at the end of the session. Thank you so much, Dr. Munira. That was an enlightening talk. We found that majority of our patients have missense mutations. So that was a good take-home message. So our next speaker is Dr. Sabah Jamal. Dr. Sabah Jamal is the Senior Director of Blood Center and Clinical Laboratories at Indus Hospital and Health Network. She is a diplomat American board in clinical pathology, histopathology, and hematology. She also known as the change maker. Her work on centralizing the country's blood banking system and making it at subpar with the international standards has been a topic of discussion in various medical circles. In 7 years, she has managed to create the country's largest centralized blood banking system in the country. Dr. Sabah will be speaking on quality assurance and blood banking in resource-strained countries. Thank you, Dr. Sabah.
Assalamu alaikum, everyone. I would like to thank PAP, PSH, and particularly Bushra for organizing this very well. And like I was laughingly saying to Bushra, the proof is in the pudding. Thank you so much. And then it was Bushra's idea of resource-strained country. And it took me a while to think about it. So it's not going to be something very new or anything, but a lot of things that I had to think, where is it money that is needed, and where is it other things that are needed, and how much of the money that is needed. At least thank you for making me think that way. The good thing about Indus is once you have convinced your bosses about certain thing, and they have the slogan of quality care free of cost. So anytime I run into any problems, I laughingly say to them, let's then take out the word quality. We should just then say care free of cost. And all the bosses now say, Sabah is about to say this. And so things get approved very fast. But this is a new way that I had to think, which I had to think in my previous organization a lot. So I have faced that at a very lower level and at the start of my career in Pakistan. The first we'll talk about what is being human. This is basically what I have faced in Pakistan, trying to put in quality assurance at the basic level. And we just were, our main thing is when we say, hum to insaan hai. I had to think about it, what do I say in English? To err is human. Whenever we make mistakes by negligence, most of us, this is the most common thing when we do an RCA, after we have an incident, that we hear this excuse, to err is human, and then everybody expects that that's enough of an excuse. So which raises the question that at what point it becomes unacceptable to err? What's that point for all of us? For when we talk about international standards, we do talk about it. International standards, I'll say within quotes. But when we get down to the nitty-gritty to our own departments, I'm not talking about the bosses. I'm not talking about anybody else. We as hematologists, when we think about it, it's a very different matter. And we also think, yes, हाँ सब इंसान हैं, मेरे पास भी इंसान है, मैं भी इंसान हूँ, etc., etc. So let's put it in the healthcare setting. What percentage of errors are acceptable? And this is one example which always comes to my mind. How often can medical personnel, basically, when you are putting my face in it, half of the slide is being cut off, so my face is not that important. Thank you so much. So what is acceptable frequency of medical personnel dropping a baby? Most of us have had babies in nurseries. So how often can we say, कि जी nurse से बच्चा गिर गया? Is it 1 in what? 100? 1,000? 10,000? A million? Will we accept if our baby is dropped by the nurse or the medical personnel in the nursery, and we say, and the nurse or the doctor says, to err is human. I haven't dropped a baby in all of my career. This is the first baby I've dropped. So, or is it never? And the funny thing is, there's always 100% consensus in any audience. I put up this example, people say yes, never. The first answer is never. So let's put this in the perspective of quality. What is our individual and collective responsibility to deliver quality assurance? And then let's put it in the perspective of blood banking. And again, let's put it, most of us who are here other than residents, either they are team leads that are sitting here, who are leading their teams, whether it be a small team or a large, and there are residents here who are the future leaders of the teams. So what's our responsibility? We are not only responsible for our own performance, we are also responsible for the performance of our teams. So a lot of it is process and process control. How are we working with our teams? When we say, oh, it's the team that did it, I didn't do it, but we are the leads. It's our responsibility. 100% falls in our responsibility. And most of the times, it's the system that is not working. It's not individuals. We have to work towards creating a system. And our main challenge is that the human resource here, especially the technologists, yes, we have now a few basically medical technology programs, but most of those programs basically don't have much practical in their work. It's all based on theory. Very rare few examples have training labs and all and have practical, but most of our technologists that come are from either biological sciences, and it's not the first job that comes in our mind when our kids are at a stage of choosing the jobs. So what we have is variable education, abilities, skill sets, and a lot of it that has to do with conscientiousness. How conscientious are we in our teams? And it becomes really insurmountable. This is for any industry, what I've said above. But when it becomes consistent quality in our suboptimal medical health resource. So we'll discuss this as we go along. In the blood banking world, at least it just takes one human error and it can kill. And this is just one example that I've taken from Dawn. There are multiple other examples. And then what we have in our countries, we have this big hue and cry, and nothing solid is done then. It's not one, these are just all tip of the icebergs. What is the critical and fundamental process defects? You know, I mostly say blood transfusion is unavoidably unsafe. This is a big tongue twister, but it is. इस पर गलती होने का चांस बहुत ज़्यादा होता है. And why is it? And why do I say that? Because a lot of blood banking work is complex and repetitive. You keep on doing the same thing again and again. The staff is doing a repetitive task. When you are doing repetitive task at a fast pace, and if it's a high volume, there is a more of a chance of error, and if it is with lower conscientiousness and less of a focus, then there is a high risk of errors. So in such an environment where there's a high risk, you have to implement certain quality assurance plan. And in most of our environment, in most of our organizations, the top level, and we even think it's a very expensive thing. And most of the bosses, when I came back from USA, even though I have never ever said in my life what is USA and what is not, the first thing, if I went with anything to my boss, his answer would be, even before listening to everything, Sabha, this is not the USA. And I would laugh and I say, did I ever say that? I am very well aware that this is Pakistan, and I've never said that. But we have to change things. So in this resource constraint, what is the cost and value of QA is always questioned in our part of the world. We are a poor nation, and I completely agree with General Sohaib. We are actually not poor, it's just disorganized, and it's our lack of priorities. We spend a lot of money, and if you see a lot of things, we do not prioritize. And then, even though we all know that its own quality is just a spoonful of medicine, which is provided by an effective quality assurance system that provide important relief from erratic performance. And that is what is happening here. And that erratic performance has to be controlled. And basically, when I think about it, and I think my take home to you just will be at the start, anything that I put in the operations of that where helps operations meet its requirements every time without fail. Har dafa sahi kaam hoye. And if I don't know it, it's really the system should be, no news should be good news. But most of our country, it's not good news, it's lack of awareness. And it has to let me know where it is failing. No matter whether it is in Badin, we now have, alhamdulillah, 200,000 donors being collected. We are serving 7,000 beds across the public sector, and believe me, it's a lot across the public sector. Only 10–15% is at the Indus sites. So the rest of it is where we have no control over the administration, and we have no control over the clinicians, because those are all public sector hospitals. They don't report to us. But it's doable. You have to have a system where you get to know something is going wrong. So let's review, how much money does it take? Basically, human resource quality assurance, we start talking about reprimand and quality assurance and everything, and we don't talk about our HR, how trained they are. I have a very strong belief in that if you have a strong quality assurance program, you need human resource capacity building, and you need that from the start. Then it just is simple. Equipment control. Why is it not moving? Reagent, component quality assurance. I have put in here unit verification because in most of the centers that I have either audited, have gone through, the unit verification is not done, and we'll discuss what it is. Please, meri shakal hata dein, please. Again, audits are very important, and we'll discuss why. Proficiency testing, what we call as EQA, that lets you know, and that EQA, when we discuss, it has to be EQA. You can't cheat. It has to be part of the whole process, not that the best technologist does it or the supervisor gets up and does it, then the supervisor has to do everything all the time. So a lot of times we really cheat at when we do proficiency testing. It has to be part of the system as your patient testing is going on. And we do get failures. Believe me, we do. But that's fine. That tells us there is a failure, there is a problem in the system. Let it be. It's not necessary that you score 100% all the time. It should reflect your true human resource capacity. And this is also very important. Like anything else, transparency is very important in our country because, again, I will agree with Dr. Zohaib that the whole country has a mindset. We do not have independent investigation of non-conformances. It's very biased. And that is very important because otherwise you can't get the root cause. And then finally, accreditation. Believe me, we have gone and we are still going through a lot of accreditation. It makes you fine-tune your system. What you think is, oh, I've created such a good system, but once you start going through the accreditation process, you realize how many gaps there are. Human resource quality control requirements, basically, let's all think about it. Aap sab ye sochiye, think about whoever is running a blood bank. Ek mera shikwa aur hai, which I will say. Most of us FCPS hematologists or any hematologist, whether it's MPhil, American boards, or most of us do not want to work in the blood bank. Blood bank is a liability for us. We love I was a diagnostician before I changed that cap. My field of expertise was flow cytometry, bone marrows, immunohistochemistry. We love all that. It's very exotic. This is systems. And the blood bank is part of a hematologist's other responsibilities, and which is largely left to the technologist. The hematologist just comes in when there is a big chaos about something. Something big happens and the top bosses call you. We are not involved at the ground level. How many of us are really involved at the ground level at what is going on in our blood banks? Because most of the blood banks are along with the laboratories, and the hematologists just have this excuse, we have too many things to do. And I think all of us know that's what has happened. And I have faced this, and again, FCPS people are, even in training, we are just training for the exam. We have hired over the last few years, 3-4 years, 8-10 hematologists. And believe me, most of them are FCPS. And once we have hired them, almost 90% call me privately and say, we need to be trained. We are not confident about blood banking at all. Basic immunohematology has to be taught to them, and then we have to do it very discreetly to train them. So residents, please, do not just study for your exam. That's a major disillusionment I got in the last 5 years, that there is a major, major gap in understanding of hematologists for blood banking. So the SOPs have to be there. This is very basic. You have to have a list of competencies where you know where your staff is. Are they competent or not? Somebody has to check, and competent as per your SOPs. Not that they have been in any other blood bank. Oh, this person has been working for 20 years or 10 years. Somebody needs to check, are they competent on your SOPs? And then each staff member must be trained, achieving that. What is the implementation? SOPs, people will say, oh, that will take money. Most of our blood banks are underworked and overstaffed. They are small pockets. It's not yet a centralized system. So there's too much staff there. They do not work all the 8 hours. So SOPs can be divided amongst them, and they can write it. And the SOPs will, and implementation of the SOPs will ensure that repetitive tasks by multiple staff get done the same way. If it is not clear to them, they will not do it the same way. What's the cost? Smaller blood banks, you just give the tasks to certain as a secondary job where they have time to train other people. I have done this in my previous life at Zardin. There was enough time for people to train other people, but in bigger hospitals, you do not require too many people. Even at Indus, in big regional blood centers, we have one dedicated trainer who is an expert blood banker, who does bench at least twice a month so that they do not forget. They have to retain their competencies, and they do extensive trainings for the whole system in that region. So in bigger setups, a single dedicated person is very easy because that's their KPI. So you evaluate them, how many people you train, there is a whole system. But in smaller systems, one person. But what is the critical factor? Consistent follow-up by the hematologist, and the belief that my role is the biggest role. Major thing, my life even today is 60% follow-up in this country with everybody. Equipment quality assurance, if you see calibrations, I won't go through each. Either it's monthly, quarterly, or biomixers are day of use. Your routine staff does that. So do you need extra staff for it? No. But how many of us have systems where we have calibrated instruments? Very few. How many of us, for that matter, have zerofuges? We are still working with centrifuges. That's not for blood bank immunohematology or serology. And how many of us who have zerofuges have it calibrated? How many cryofuges are calibrated? And then we talk about red cell contamination in the platelets, and we talk about platelet clumps. It's all because our cryofuge is not calibrated. So you don't need it either yearly, or if your QA is failing, then the first thing is you go and see what's happening to your calibrations. Do you require extra staff for this? No. It's your routine staff that has to have the competencies to do it. Again, the critical factor is us. Are we following it up? Do we have a control over it? Are we going into our systems? How are we involved in our day-to-day activities? Again, it's this hemoglobinometer, immunohematology. If you see, most of it is daily, which starts with the daily work. Components also, it's just monthly. And again, it's us. If you just have one quality assurance meeting a month, and the HOD sits and sees all the data, even that is enough for the team to do it consistently. Our major problem is consistency. Again, if you see, I'm not going to go through, all of this is in the books, but it's the part of implementation. Unit verification. What is happening? What is unit verification? What is unit verification? जब हमारा सारा our whole blood group, all the processing is done, blood grouping हो गई, आपकी TTI testing is complete, etc., etc. Then somebody, if you are doing it manually, we have done it manually, you need 2 people to check, say it aloud, this is this, and do it. It's doable on paper for small setups. The only thing is it has to be done daily. What is happening in our blood banks? we do not quarantine. The same blood is in the fridges. When we get the request, the people are going to the registers or checking, okay, what is positive, what is negative, and we do that in a panic, and I'm pretty sure we are issuing wrong product. The best thing is have a unit verification time daily, either in the morning, whatever time you adjust, and all units, there should be a separate quarantine fridge. You can have a reagent fridge where you keep it, your tests, where you're in quarantine, your units, till all testing is complete, and it has to be in a separate place where nobody picks up that unit from that fridge. And bring it into your inventory, your issuable stock, when you do your unit verification. If you have softwares, a single person can do it. Softwares do the background checks. But softwares, anything, no exotic thing is necessary. You have to do it on, you can easily do it on paper. And why is it vital? It's major vital. Even if you're doing all tests and there is no quarantine, there is a high risk of issuing infected unit. Again, what are the process control techniques? It's just a matter of, we all know the processes, steps of the process. You create the process and you put in checks and balances for your process control. And that's just training and competencies. This, you cannot put enough emphasis on this. Continuous annual training, it has to be there. Your EQA or proficiency testing, your monthly, please have your monthly QA meetings, otherwise you will not have a control over it. The staff needs to know that things are being supervised. Operational internal audits, which is called clinical internal audits, that are very important. In our system, because we are working in quite rural areas, we have put in CCTV. There's no other way we can control. So we have high resolution cameras even over our serology and everything, and our QA staff sits and does random audits once a month for each and every staff, and we see somebody diverting from SOPs, that individual then goes into an extensive audit. Because if you are sitting at a head office in Karachi and you are moving into the rural areas, there is no other way of auditing. And we have physical audits as well as CCTV footage audits.
Dr. Sabha,
Ji.
can we...
So surprise competencies, this is all there is. And quality audits, again, you provide the comparison and you do you know what is the degree of inadequacies, you put in the feedback for improvement, and you have to have root cause analysis and corrective actions. These are all non-conformances. Have your investigation reports. If you have a BBMIS, you'll have these alerts. Just see this, just by our BBMIS, this was published, we detected mere errors as it was happening. So if you look at percentages, I'll just go through it fast. Percentage looks very good, 0.3%. But blood banking, if you look at the frequency, 1 in 332, 1 in 1,000. Wrong expiry label, wrong sample drawn, 1 in 400. And the software was checking, so it stopped the system there and alerted. So it is possible. Frequently asked question is, how many staff do you require for QA? QA is everyone's responsibility. Do you know, I'll just finish by telling you, when we started at Indus, because at Ziauddin we didn't have separate QA, and we started with one QA person, and who was basically a relatively junior than the others, and I chose that person because of her resolute and standing against the opponents and not backing off, and her 100% honesty under highest pressure. You need that kind of a person. If she would identify something, the response from most of the texts were, get it done yourself. खुद कर लो, अगर ऐसा है, तुम्हें इतनी तकलीफ है, खुद ठीक कर लो. And that is why we stopped her basically reporting to anybody. In Indus, Quality Monitoring Directorate reports directly to the board. Now she doesn't even report to me. So there is no pressure on those individuals. about anything. So basically, even in our large system, we have one per regional blood center, that's all, not one per hospital blood bank. And who is responsible for corrective actions? I feel everybody is, but it's our duty as the heads. Whether the corrective action is being implemented consistently, and the main thing is have continuous post QA audit. Once you have found something, somebody needs to check repeatedly if it's implemented. Then you can put it in the routine. So this is what I leave my message with. Change the way you do blood banking. Let's change the blood banking world in Pakistan.
Thank you so much, Dr. Sabha. Now we'll start the panel discussion.
our differential of samples with abnormalities, that is one of our considerations. I don't see it in the internally prepared samples, so I do think process control is really important. Where we seem to have more errors is samples collected from big private laboratories that get shipped maybe 4 or 5 hours before they're separated off into components and then sent to reference labs. Those are the ones, if we get a patient referred with a low factor VIII, von Willebrand factor abnormalities, that we often can't reproduce the abnormalities that the patient was sent to us for, and have to conclude it was a pre-analytical error.
My question to Dr. Sabha about quality assurance. In what I have observed, that the greatest hurdle in quality assurance is the honest working, honest staff, doctors and non-doctors both. What do you say, and how you could manage it? Because it appears that your quality assurance program is very strong, and not only in Karachi but even in the rural areas.
Well, what we have done is, again, the QA staff does not even report to me, so they are under no pressure. Initially, like you said, once we had this model, the heads had, whoever we hired, almost everyone had a big, almost shouting match with me in my office. How dare you not, how dare the quality assurance team report not to me? And I was like, this is the industry rule. It is not, I'm one of the architects, but they don't even report to me. In this country, they have to have the support that their annual appraisal is not done by us. They are auditing us, so they are, first of all, they are without any pressure. Quality Monitoring Directorate of the clinical service, of the lab, of the blood center, all of it reports to the Director, Quality Monitoring Directorate. And she reports to the board directly. She doesn't even report to the CEO. So all of that group is doesn't have the pressure that they will be evaluated, number one. Number two, we have done it by very extensive trainings. It cannot be reprimanded without training and putting in the conscientiousness. So it's really because there is a turnover, so it becomes very challenging to keep on training and keep the level of the motivation of the trainers there, that when people leave and we train people, and even somebody we terminate because of negligence, higher level of willful negligence, people seem to hire them. Oh, you are from the Indus system? Oh, they'll be still better than ours. So we do not have that licensing thing in our country. So, but then you just have to do it, and our CCTV footage and continuous auditing and continuous, it's just a lot of continuous. Shabnis is smiling. She has realized how much continuous it is for me, and now she's being trained to be that continuous. But eventually, we still have failures. We do not hide them. We do not even hide at the biggest forum. You have to be under highest pressure. No matter what happens, we are not going to lie. Once you start doing it yourself and you tell the staff, where are payments, because we have auditors every 3 months, and the government pays us based on our KPIs. And you know, staff. So I have had to stand the ground, and I will really commend the Indus top team, where we have had, people have told me, let's fake this data. And I've said, no. It will go as is. And auditors have told us, your amount will be slashed. That will be paid to you. I've gone to our CEO, Dr. Bari, and I've told them, I've taken this decision, may it be slashed. My team has to know nothing will be faked ever. If I do it once, I can't stop them from doing it. It has to be 100% honesty and acceptance at the highest level. So then the staff knows that, okay, no matter what, And again, there will still be failures, but we have our successes. So that, and the involvement of the top team, that I feel that is the biggest thing, and it's you know, rests on us to keep the morals of the team up, that it's okay, this has happened, we'll move on, we'll learn from this, we'll create an opportunity from this challenge, and you will not be affected, I will be affected, I'll be at the forefront. So it can be a bit challenging when people are screaming and shouting at you, but then you just stay your ground and be honest. Yes, this has happened, we have the same kind of human resource, we will do better next time.
Just a little bit to what Dr. Sabha is saying, just a little 1 minute. You must have heard about X and Y theory. I don't know whether everybody has heard about this or not. This is about the non-punitive show to the technologists. That is, there should be an environment where the errors and mistakes are not concealed, but they are openly discussed and be taken as an opportunity of learning and doing corrective actions and preventive actions for preventing errors in future. Because if you have a punitive kind of approach to the technologists and to your staff, then they will, because they will know that there's something going to happen after each mistake, so they are going to hide it. They're not going to bring it to you. And you cannot be present, like Dr. Sabha is talking about CCTVs and audits. It's really very challenging to do it all the time. So it should be an open environment where the mistakes are discussed in the quality assurance meetings or in sectional meetings, where there's an environment where the technologists feel confident and they should bring that mistake, and they should be volunteering how to improve the situation and to bring the corrective action. But if you start punishing your technologists and staff for every mistake they do, believe me, they're going to hide it, because they work as a team, and you'll never know that what is happening, especially at the nighttime and the evenings when you're not even there. So you have to bring an environment that fosters these errors and mistakes. They accept it, and they bring about a change in the environment. It should be a friendly environment, not a punitive environment.
Thank you, Dr. Bushra. This is a very important aspect that we should be practicing in our labs. And in addition, I would say, just to add on what Dr. Sabha has said, the accreditation process, it is very important, because you learn a lot. You think everything is going smooth in your lab and there are no mistakes, but the accreditation process takes you a long way of learning and building up your department and training your staff, the staff that is working there. So that is very important. We should be participating in some of the accreditation process to make things better in our blood banks. And also the staff that I prefer is the one who is not trained, so that I train the staff and they work according to the protocols. So the already existing trained staff, they don't work with me in most of the times.
Any other question, please?
Assalamu alaikum. My name is Yasser. I have a question for Dr. Sabha Jamal. Dr. Sabha, you have talked about human resource trainings and equipment and units and CCTV quality assessment. I just want to know how vital is the role of software used in blood banks for quality assurance?
It's very helpful, very, very helpful in a larger system, but you can still have quality without softwares also in smaller systems. But now these softwares are available, so they do help a lot if they are identifying, but you can have quality without softwares also. If you have really a written down process, that's the main thing. They are not the turning point of, yes, if you don't have a software, you can't have quality. That's not how I feel about it.
I wish General Swab had been here, I would have asked him a question, just comment about his presentation, a very nice presentation by General Swab. But whenever we compare Pakistan with Iran or Greece, there is a huge difference. The population of Greece is only 11 million. Our population is 220 million. And we when talk about Iran, the population is only 85 million. So there's a big gap there. But there is definitely, with these, all the effort, with all the Thalassemia Society's efforts and these lectures, there is a trickle-down effect. People are becoming aware of these problems and they are consulting the hematologist. I'm sure with the passage of time, we should not target that we should have 100% free Thalassemia Society. At least we should target, at least we can reduce it to 20%, 30%, 40%. That will be a big achievement in a country with a population of 220 million. That was all about this session. Now I'll request Dr. Shabneez to
Now I will request Dr. Catherine Hayward and Dr. Nadeem to present the shields to our speakers, please. Right, so our first speaker is not here, but if General Suhaib can accept on his behalf. Yes, General, please can you accept the shield on behalf of Dr. Suhaib Ahmed, please? Thank you so much. Thank you. Now I would like to call upon Professor Dr. Nisar Ahmed, please. Thank you so much, Dr. Nisar. And now I would like to call upon Dr. Munia Burhani. Dr. Sabah Jamal, please accept your shield. Thank you. Okay, so now with this we end our shield presentation and we go on to short talks. I would like to request all the speakers to stick to their time limit, and we'll start with Dr. Sidra Azhar from Buckeye Medical University, Karachi, who will be speaking on printing the fingers of blood for early cost-effective prediction of anemias. Dr. Sidra, please. Yes, you have 7 minutes to complete your presentation, please.
Assalamu alaikum all. My name is Dr. Sidra Azhar. I am from Buckeye Medical University. I'm a hematology scholar. First of all, I would like to thank Professor Rafiq Khanani and Dr. Rana Zishan Haider, whose firm belief make this dream come true, and Pakistan Association of Pathologists. My title is Printing the Fingers of Blood for Early Cost-Effective Prediction of Anemias. Now very quickly, what are the highlights of the article? They can be divided into 3 portions. What are fingers of blood, printing, and anemias? As we all know, in fingerprints, there are some cumulative pattern that are ridges, valleys that are accumulated on the minute point, and then the finger detects them. Now, the modern hematology analyzers, all we think they can be generate this in the form of scattergram. Now, basis of scattergram, they can be work on the principle of electrical impedance matter or a flow cytometry. In flow cytometry, one cell can be passed and the cell granularity, their volume, their all can be measured. This is the scattergram into quantitative values. In machine, we can be develop these scattergram into numeric values, and this is called as cell population data. Now, the second element is printing. What do we all know about printing? Well, it's great that we can develop this scattergram, this fingerprinting, but a human mind is not very sharp to recall all this high dimensional data, and then they can reproduce it. Of various possible patterns among this kind of high dimensional data. Not other than the brain, that is artificial intelligence. Natural versus artificial brain, as we all know as a doctor, that our neuron have a cell body, dendrites, and then the synaptic cleft. Likewise, in inputs, we have entered the data from the patient artificially, neuron, then activation function, and then output is the disease. So in our study, we have prospective studies. Study setting can be Buckeye Institute of Hematology, National Institute of Blood Disease, and for this artificial intelligence, Computer Science Research Department of NAD University. Study duration of 6 months. This was the inclusion-exclusion criteria. My study group is about 10 study groups. First, we enter the raw data, then parameter filtering, then data pre-processing, machine learning algorithm, model training, CSV patient research report, extract the required CBC research parameters, processing the parameters on trained models, and then display the result. Either anemia is found and either anemia is not found. If anemia is detected, along with its types. These are basically the differential diagnosis algorithm I have used in my study. Now, the third part is prediction of anemias. How we will be able to use this artificially intelligent brain in our study. This is known as heat map, which we've developed by using all these research parameters, and in the bottom there are study groups like hereditary spherocytosis, hemolytic anemias, mixed deficiency anemias, and in my cases there are 91 cases of hemolytic anemias, there are 273 mixed deficiency, and 1260 is iron deficiency anemia. Now this heat map, how it works, it can show the cold and hot spots and unique pattern for thalassemia intermedia like fingerprinting, as I already told. Likewise, principal component analysis, PCA plot we have used. They can show already elaborated study groups. Still, we cannot very much differentiated between some closely related points. So when we apply the model results, so the random forest, which is one of the type of machine learning algorithm, is having the precision score of 91.92% in my study. Sorry. Goals to be accomplished in future: enhance the accuracy of the system. As the system is safety critical system, the accuracy must be sufficient enough before putting it in an operation. Enhancing the security is to be tackled. Deployment of machine learning algorithm or model has been trained. Frontend has been implemented as a Flask web application. Is it possible? And visuals for identifying the ratio of the most detected type is to be obtained and display on the web page to assist the clinicians to pathologists. Now, what are the conclusions? Cell population data, CPD parameters are the potential morphometric parameters. The list of the differential diagnosis can be shortened through these extended CBC parameters. Artificial intelligence, more time available and less infrastructure required. As one study is World Innovative Medical Forum, in which Harvard Medical chairman said that 70% of the pathologist load can be decreased if we are using or incorporating artificial intelligence in our center or in our study. Time is essential to the quality of care patients receive. Acknowledgement to the authors. This is my team. Thank you.
Thank you so much, Dr. Sidra.
Thank you.
Thank you for your talk. Okay, so now our next talk is by Dr. Harim Alam. She's from AKU, and she'll be speaking on the significance of red cell alloantibody screening in routine pre-transfusion setting, data from a tertiary care center. Inki presentation, please.
Okay. Assalamu alaikum everyone, this is Dr. Harim, resident hematology from Aga Khan University Hospital. Today I will be sharing our experience on the significance of red cell antibody screening in routine pre-transfusion testing. So I have no conflict of interest to disclose. So this presentation will start from a brief introduction, followed by objective methodology, results of my study, and then concluding them. So as transfusion medics, we are the persons who are responsible for making the blood transfusion safe as much as possible. Besides the transfusion-transmitted infections, there's also possibility of transfusion-associated hemolysis. And to minimize this risk, certain tests are performed in blood bank to reduce the chances of transfusion reactions in the patient. In majority of blood banks in our setups, the pre-transfusion testing includes the ABO and RH typing of the donor and recipient, followed by cross-match, that is the testing of the recipient serum with the donor red blood cells. An incompatible cross-match is then proceeded with antibody screening, and if positive, then identification. The purpose of red cell antibody screening is to determine the presence of any atypical red cell antibodies that are likely clinically significant. However, in our majority of our blood bank setups, this step is not performed in case of a compatible cross-match. So here the question arises, can red cell antibody screening be positive when cross-match is compatible? And the answer is yes. Definitely, if the donor red cell is doesn't lack the corresponding antigen to the antibody in the recipient, the cross-match will be compatible. However, there are certain other reasons which can cause a compatible cross-match despite the presence of corresponding antigen on the donor red cells, which will I discuss later. Another question, is the antibody screening still needed when cross-match is compatible? Do we need to make the antibody screening a part of routine pre-transfusion testing? We should. But why? So, the sensitivity of cross-match to detect red cell antibodies is less as compared to the antibody screening. And the reasons is because of the variable expression of antigens on the donor cells as compared to the screening cells. Here you can see an example. That the patient has anti-JKA while the donor cell is homozygous, so the reaction is strong. It can be picked by cross-match. In second example, the donor is heterozygous. That's why the reaction is weak, and it can be missed by a routine cross-match testing. Secondly, these screening cells are preserved at better conditions, and thirdly, the cell suspension is more standardized in case of a cross. So keeping this in mind and following the guidelines, we implemented this policy in our setup in January 2022. So this is the guideline from the British Society of Blood Transfusion and also endorsed by American Association of Blood Banking to include the antibody screening as a part of routine pre-transfusion testing. So this study was to consolidate the significance of red cell antibody screening in pre-transfusion testing. It was a cross-sectional prospective study held at blood bank of in which all the samples that were subjected to pre-transfusion testing were included. Red cell antibody screening was performed. The data was collected from in-house system and then was analyzed. So here you can see that the total samples subjected to pre-transfusion sampling in the study period was around 38,000, and 151 cases were positive, showed positive antibody screening. So the rate of immunization in this study was 0.4%. Few seconds on demographics, there were 32 million. Previous identified antibody in our system. The highest incidence of alloantibody was found in the group of patients who were transfused because of obstetric complications, followed by hematological disorders. So here you can see that 117 out of 151 patients had a compatible cross match with positive antibody screening. This means that this number of antibodies were missed by the cross match. They were not picked up by routine cross matching. But here you can see that 60% of the patients, 60% of the patients were Rh negative, so they're by default cross matched with the Rh negative blood, so they came out to be compatible. But we were more interested in that 40% of the patients who were Rh positive, they were compatible cross match, but the antibody screening was positive. So this is the distribution of different antibodies that was encountered in 151 cases. Let me arrange this data for you. So here you can see that in the Rh negative recipients who were compatible with positive antibody screening, the most frequent antibody was NTD. But let me tell you here that 75% of these female patients receive NTD prophylaxis. However, you see in the second group who were Rh positive, compatible, and positive antibody screening, the most frequent antibody was NT-big E. NTK was also identified, NT-JKA and NT-duffy A, while some antibodies were clinically insignificant. So if I summarize my data in one line, besides NTD, 34 patients had antibodies that were not picked up by routine cross-matching. They were missed by the routine serological cross-match and then picked up by antibody screening. So they could have been implicated in transfusion reactions, and they could have caused immunization. But we dispense the antigen-negative blood to the patient then. So concluding my study, this study provided an insight of significance of red cell antibody screening in pre-transfusion testing in our local setting. Antibody screening should be done to ensure that the transfused blood components have adequate survival when transfused and do not cause harm to the patient. We recommend that dispensing antigen-negative blood cells can prevent red cell immunization in the recipients. I will end up my presentation here by saying that red cell antibody screening seems one of the missing link of pre-transfusion testing that can help us to unlock the journey of making blood transfusion safe as much as possible. Thank you.
Thank you so much, Dr. Harim. So we'll go on to our next speaker, Dr. Zunaira Mughal. She's from King Edward Medical University. She'll be speaking on greater viral load in novel coronavirus is associated with increased inflammatory markers in plasma and poor hematological parameters, leading to adverse clinical outcome and higher mortality. Please, Dr. Zunaira.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. I'm Dr. Zunaira Mughal, postgraduate resident hematology, King Edward Medical University, Lahore. Today, presentation please. Today I am going to present my research titled as Association of Viral Load in Novel Coronavirus Infection with Hematological Parameters and Inflammatory Parameters, the Clinical Outcome and the Mortality. Moving on to a brief introduction, as we are well aware that coronavirus disease is caused by severe acute respiratory syndrome COVID-2 virus that has caused immense havoc in the recent years. The disease presents with a wide range of clinical symptoms, ranging from asymptomatic to very severe disease. The classical findings include the raised levels of inflammatory markers and various disturbances in the hematological parameters. The objectives of our study were to determine the viral load in the patients admitted in COVID-19 isolation, correlation of the viral load with the inflammatory markers and with the hematological parameters, and following the clinical outcome in all the patients. We hypothesized that there is a positive or significant association of viral load with the hematological parameters and the inflammatory markers, and this can affect the outcome of the patients. It was a prospective cross-sectional study conducted in a joint venture of Pathology Department of King Edward Medical University with Doctors Hospital over the span of 1 year. All the patients who were symptomatic and tested positive for coronavirus on reverse transcriptase PCR and who had no previous history of any comorbidities were included in our study. However, the patients who were symptomatic but tested negative and who had any known comorbidities were excluded from our study. The nasopharyngeal swab of all the patients were analyzed to detect the viral load, the unit of which was cycles threshold, and the level of acute phase reactants and the hematological parameters was observed at the time of presentation in all the patients. Moving on to the results, total 86 patients were included in our study. The mean age of all the patients was 63.95 years, the male to female ratio of 3.3:1. This is the data that we obtained from all our patients and the mean values of all the parameters that was observed in our included patients. To analyze our patients, we divided all our patients into two groups depending upon their viral load, taking 30 cycle thresholds as the cutoff values. Similarly, all the other parameters was also divided into two groups to analyze the results. This table shows the association of the viral load with the observed parameters, and we observed that the low absolute lymphocyte count of less than 0.8, raised interleukin-6 levels and raised D dimers were positively or significantly associated with the viral load of more than 30 cycle thresholds. This is a graphical representation of the previous graph. As we can see that 82.6% of the patients with viral load of more than 30 showed low absolute lymphocyte count. Similarly, 91.3 and 82.6% of the patients with viral load of more than 30 cycle thresholds had raised interleukin-6 and D dimers levels. The clinical outcome was seen in the patients that showed a mortality rate of 14.2% and male to female ratio. As we can see that females, among all the females, the mortality rate was higher as compared to males. Now this table shows the association of the clinical outcome with the observed parameters, and we can see that the absolute lymphocyte count that was low in the patients who died. Similarly, platelet count of less than 150 was seen more in the patients who died. Raised procalcitonin, D dimers, ferritin levels were also positively associated with the mortality. Similarly, the patients who died had high viral load. This is the graphical representation of the results that I discussed previously. We can see that 88% patients who died had viral load of more than 30 cycle thresholds. Similarly, 88% of the patients had raised D dimers and interleukin-6 levels. 92% of the patients showed raised ferritin levels and LDH levels. 80% of the patients had low platelet count in our patients who died basically, and the absolute lymphocyte count of less than 0.8 was seen in around 80% of the patients who died. So concluding my results, I can say that lymphopenia, raised interleukin-6 levels and raised D dimers showed significant association with the increased viral load. High mortality rate was seen among the patients with thrombocytopenia and lymphopenia among the hematological parameters. The LDH, D dimers, procalcitonin and ferritin levels were raised in the patients who died, so showing a positive association. Similarly, viral load had also a positive association with the mortality rate. Concluding my results, that hematological parameters and inflammatory markers can serve as novel prognostic factors and should be included in the routine investigations in all the patients who are diagnosed with COVID-19 infection. The study will be helpful in predicting the possible prognosis in the patients, thus helping the clinicians for better management of the patients. Obviously, there are few limitations in our setups. That includes the small sample size and detection of the viral load by using only nasopharyngeal swab. Similarly, the serial levels of inflammatory markers were not taken for better prediction of the disease outcome. Thank you so much.
Thank you so much, Dr. Zunaira. Now we move on to our next talk. By Dr. Kinza from Khyber Medical University, Peshawar. She'll be talking about the frequency determination of C1115 and 1118 deletion, TTGG, and another deletion, basically FANK-A gene mutation in local Fanconi anemia population.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Kinza Ayas. I'm currently working as postgraduate trainee at Hyderabad Medical Peshawar. And this study, this research that I want to share with you, this I done during the course of my MPhil hematology. We studied these two mutations in exon 13 and 38, which are common worldwide in our local Fanconi anemia population. So just a brief introduction to Fanconi anemia. As we all know, it is an autosomal recessive inherited aplastic anemia, which comprises of hypocellular bone marrow. And the patient present with various somatic abnormalities. They have hypersensitive cells to DNA cross-linking agents. The patients have increased vulnerability to acute myeloid leukemia, myelodysplasia, and solid tumors. The reported incidence is 1 per 200,000 to 400,000. It's more common in Ashkenazi Jews and Afrikaner population, but it was relatively more common in our population as well. So the basic defect of Fanconi anemia, it lies in the DNA repair pathway. There are different genes which form different proteins, and they take part in the DNA repair. So as any mutation resulting in any defective gene can lead to defective DNA repair, and which leads to accumulation of different mutations and then subsequently leading to different CAs and AML. So the most commonly mutated gene is the Fanconi anemia A gene in the whole of the complex of 16 to 18 genes. As we see that the Fanconi anemia A gene is located on chromosome 16. It has 43 exons and size of 80 kilobytes. The protein which is formed is of 1455 amino acid chain and a size of 163 kilodaltons. Most of the Fanconi anemia patients presenting have this Fanconi anemia A gene mutated in them. So the rationale of my study was to determine the frequency of these most commonly reported Fanconi anemia A gene, which was reported worldwide, whether they are common in our population or not. We wanted to devise an ARMS PCR because we wanted to have another sort of a diagnostic test, just like thalassemia, which is other than the gold standard test of chromosomal breakage test. Is a laborious procedure. It is time consuming. It needs expertise, and it takes a lot of money for our poor patients. So the first one was to determine the frequency of most common these mutations. Then after the approval from the Advanced Scientific Research Board and Khyber Medical University Ethics Board, we did this cross-sectional study of consenting patients. 17 patients was included, and they all had the characteristic physical features of Fanconi anemia. And most of them had Fanconi facies. Some of them had, actually one of them had absent kidney, and a few of them also had the skeletal abnormalities as well. The lab work was performed at the Pharmacogenomics and Hematology Laboratory of Khyber Medical University. So we recruited the Fanconi anemia patients which were either already diagnosed. Some of them also had the chromosomal breakage test analysis with them, and the bone marrow aspirate report as well. We took informed consent. We did an elaborate pedigree analysis of 3 generations. Then we performed the physical examination. We collected peripheral blood and stored it later on to be sample processing. We extracted the DNA, we performed the PCR, and then we sent the samples for Sanger sequencing to Korea. Most of our patients presenting were males. 76% were males and 24% were females. Most of these children were presenting in the age range of 6 to 12 years old. This is the demographic representation. Most of the patients presented from different areas of KPK, and 2 patients actually presented from Afghanistan as well. Most of the patients had, almost all of them had pallor and easy bruising, and most of the patients had the typical Fanconi facies with slanting eyes and hyperpigmentation as well. Most of the patients had severe anemia of HB less than 8 when they were presenting, and the bone marrow hypoplasia, most of them had bone marrow hypoplasia on their reports. The physical finding, all of them had Fanconi facies and some had skeletal abnormalities along with them. The family history was positive in most of the patients. They had another family member who was either diagnosed with aplastic anemia or who had died or was still under treatment. These are 2 of the pictures from our patients. You can see the duplication of thumb in the first one, hyperpigmentation, floating thumb, absent thumbs. They were characteristic findings of 2 of our patients. In this pedigree analysis, if you can see, it's of 2 patients actually, and they are first degree cousins. And the first one patient, who was a female, she already had a sibling who died of Fanconi anemia, and now she was presenting with Fanconi anemia, and she had a cousin who was also presenting with Fanconi anemia. This is another female child who unfortunately died during the course of our research, and she had Fanconi anemia. She was diagnosed at 1 year of age, and her family had a history of solid tumors like thyroid tumors and liver carcinomas. So we extracted DNA by manual method. Just we wanted to cut the cost of this test. So then we amplified it with an ARMS PCR. So we amplified the exon 13 of Fanconi anemia A gene, which was corresponding of one of the deletion, that's 1115 to 1118 of this nucleotide TTGG that was deleted. And we also, we amplified, actually, we did it in 2 ways. First, we amplified the normal, and then we amplified the corresponding mutated gene as well. And we also did it for exon 38. This is the picture from the PCR. Then we sent these samples to confirm our results of ARMS PCR to Macrogen Korea for Sanger sequencing. And we found 4 SNPs, but they were most likely benign, reported as benign. 2 were in intron 12 region, and 2 were in exon 13 and 38. They were actually confirmed by different variation databases as well. It was actually an incidental finding. We performed both the forward and reverse primer to confirm the presence of these SNPs. Actually, this is for the SNP. It's a result of both forward, and the other is the reverse primer. So the conclusion of my study was that fortunately or unfortunately, we were unable to report these commonly mutated mutations in our population. And as our population, we all know that it has a totally different ethnicity and background. So we need extensive studies for our population to know about the common mutations in our Fanconi anemia populations. The SNPs were incidental findings, and they were non-pathogenic. These are some of the references. If you have any questions, thank you.
Thank you, Doctor. Thank you very much. Very nice presentations by all the speakers, short talks. Just one comment, वो डॉक्टर सिद्रा ने कहा था कि आर्टिफिशियल इंटेलिजेंस से पैथोलॉजिस्ट की ज़रूरत नहीं रहेगी. पहले बहुत सारे पैथोलॉजिस्ट फिर रहे हैं, आप बाकी के भी दर पे हैं कि वो भी चले जाएं यहाँ से. तो आई कैन अश्योर यू पैथोलॉजिस्ट आर indispensable. You cannot replace pathologists. During the last 35 years I've seen. So with this, I am grateful to all the speakers and all the audience and we are coming to end of this session. Thank you very much.
So now I would like to call upon Dr. Busha Moez and Dr. Nisar for a shield presentation to Dr. Mohammed Nadeem, please. Thank you. Thank you so much. Right, so the most important part of today's session, lunch. Okay, so lunch is being served at conference room B for faculty, speakers, moderators, and for others they can go to Zevar Hall. Okay, thank you so much. Thank you. We start again.
The benign disorders, they form a very small fraction of indications. Now, what are the challenges that we face in doing the bone marrow transplant and making it sustainable facility? There is fragmented and underdeveloped healthcare system. And we know that, except for big cities and selected places. इसको आप खत्म कर देंगे ये इसको here. Then there is lack of the transplant registry and data, and lack of awareness and prevention program for genetic diseases like beta thalassemia. Now coming to the national figures, this is the update till December 2021. Total number of transplant carried out are 3,380, and around 25%, close to 25% are the autologous, majority are the allogenic transplants. Now this is in sharp contrast to the international data, in which the autologous transplant is the #1 indication for transplant. This is followed by the allogenic. Now, if we talk of the various centers, the number of transplants done till December 2021, the biggest center is the Armed Forces Center. This is followed by the NIBD, then Aga Khan Hospital, Shifa International, and rest are a bit newer centers. They have started in the recent past. Now, indications, as I've already mentioned, that the beta thalassemia is the top of the line indication with 842 transplants. Then this is followed by the aplastic anemia, and the leukemias. they are AML 316 and ALL 210, and the leukemia they are hardly about 20% of all the allogenic transplants. Now this is 1 year data of proportion of the autologous transplant versus allogenic transplant. In majority of the places, the allogenic transplants are the major indication, and the autologous are not much, except for 1 or 2 places. The allogenic, or the top indication here is that in the Western Europe and in the developed world, there is very small fraction of transplant that are for non-malignant hematological. Is hardly present elsewhere or Middle East, and aplasia, of course, it is there, but majority are old age people and don't go for transplant, so they form a very small fraction of indication. There have been quite a few number of haploidentical transplants performed over the past 5 to 7 years here. Majority are in the aplastic anemia, because most of these severe aplastic anemia, they die if they don't get transplant. Rest are the malignant disorders. Now, identical transplant, it is one of the recent development, started about a decade ago, because of the discovery of post-transplant cyclophosphamide as GVHD prophylaxis. And if we see this graph, this green line represents the haploidentical, and it is almost surpassing the match related sibling transplants, and there is even decrease of the match unrelated transplants. So this is one of the modality that has got a potential for due to non-availability of the donors. Now stem cell source as expected, because we are doing transplant in non-malignant disorders, and for non-malignant disorders the best stem cell source is the bone marrow. Here more than 50% the source of stem cell is the bone marrow, followed by the peripheral blood stem cell. And if we compare this data with less than 18 years of Western data, even there the bone marrow is the preferred source of stem cell in children, in pediatric transplant, even in malignant transplants. And while this is in contrast, in adults bone marrow is not that important source of, and the peripheral blood is the important source and the major source of stem cells. Just a brief about the survival. Survival in acute myeloid leukemia in children is a pretty good, close to 70% in good risk cases, and in CR1 is survival, while in adults it's a bit less, but still around 50 to 60% is long-term survival in acute myeloid leukemia. In acute lymphoblastic leukemia in pediatric age group, the survival is though not as good as in acute myeloid leukemia, but still it's between 60 to 70% survival, while the survival in adults in ALL is not that good. Hodgkin lymphoma, now these are the cases who have got relapsed and refractory because autologous transplant is not the standard of care for Hodgkin lymphoma, but it is even refractory cases, they are associated with 80% long-term survival. And similarly the diffuse large B-cell lymphoma, they have got pretty good survival, around 60% or 60% plus. And these are all cases who have got relapsed and refractory lymphomas. In myeloma, the bone marrow, autologous bone marrow is the standard of care, and it is associated with reasonably good long-term survival. Now coming to the cost in US is $800,000, in UK it is $500,000, and I think it is one of the lowest cost, around $20,000 to $25,000 here in this country. Even with the inflation, we are able to do transplants between 3 to 4.5 million Pakistan rupees. The resources here for transplant, majority they can't afford, but still majority have to self-finance. Others are sponsored by various organizations. Public resources are meager resources supplied by the Social Security, Zakat, Baitul Mal, and there are some discretionary fund, but they are not commonly used. Charities are sponsoring certain patients. Now how do we reduce the cost? The reason that we are able to do transplants almost 1/10 of the cost of the developed world, that we do not invest on infrastructure and equipment. We scale down the facilities, and then we select the careful the patient with likely to have good outcome. We target the curable diseases. We tailor the lab investigations. Can reduce the cost of drug by selecting the alternative drugs instead of brand leaders. Then optimal use of blood components, and then health education and outsourcing of expensive facilities. These are various measures that all of us are using. Now, I just mentioned that the quality, there is a cost of quality. If we, that curve that goes on the right extreme. If we increase the quality, the cost would be very high. And if we compromise the quality beyond a certain limit, then cost of not having the quality will also be very high. So we have to be in the middle. You need to have adequate quality so that you don't pay for not having the quality, and at the same time you don't pay for having the high quality. So if we stay here, the cost will be substantially reduced. This is one of the extracorporeal photophoresis facility recently started in the armed forces setup. And this is what I mentioned in the beginning, that the transplant group here, they have in the recent past started a group or society in the name of Pakistan Blood and Marrow Transplant Group. And the purpose is to collaborate, to start clinical trials, to share their data, and to share common protocols so that we can evolve certain innovative strategies in the management of our patients. Coming to the conclusion, blood and marrow transplant activity in Pakistan has progressed, though at a lower pace. Cost is approximately 1/10 of the treatment abroad. Reduce burden on healthcare system by curing chronic diseases such as thalassemia. The cost of traditional treatment of thalassemia for 5 years exceeds that of transplant. Then there is improvement of local medical setup, standard of knowledge and expertise, human resource development, incentive for local pharmaceutical industry, and it can promote health tourism in case certain selective places they opt for this facility and market it in the world. Thank you very much. I was worried that I may be prompted to stop by the chair, who is quite strict in time management. Thank you very much.
it dates back way in when allogeneic stem cell transplants really came about in the 1950s and the 1960s. That's when we learned about the role the T cells have to play in the GVL and the graft versus host disease effect, leading to identification of the B cells, T cells. From then on, a lot of time went into the bench work, resulting in identification of T cell restriction, identification of T cell receptors. How does the DLI work? Development of the chimeric T cell receptor in the late 80s by the Weizmann Institute in Israel.
Novel approaches in the diagnosis and management of MDS. We have been dealing with MDS patients. Previously, we know that these patients are old age patients with multiple comorbidities, and they have very limited tools available for their management. But this scenario is not changing, so let's have a look. I have nothing to declare, so this is just overview of how I'm going to proceed. Okay, fine. So MDS, as you know, has got a wide heterogeneity, which makes it a difficult disease to treat. So we have got very limited treatment options, and the reason being that the number of mutations we which have occurred in the last 10 years, helping us in understanding the pathogenesis. So this is a very colorful diagram, and the purpose is to give you an idea that in the last responsible for the different mutations that occur in MDS patients. And as you can see, they act at the nuclear level, at the epigenetic level, at the spisosome level, affecting apoptosis, TP53 mutations, signal transduction defects, and so on and so forth. So once we have got this information, the next step is a change in the classification of MDS. In the upcoming 5th edition of WHO, we have seen that they have replaced the terms syndrome with neoplasia. Also, they have introduced a new category of MDS with defining genetic abnormalities, out of which they have retained the previous one of 5q, isolated 5q deletion, but they have added another mutation, which is SFP, it's SF3B1, sorry. So we have to get around to keep learning these new mutations. And the other one is the biallelic TP53 mutations. And not just this, but then you have to exclude some other mutations, which means that an extensive molecular panel of tests need to be done in these patients. Morphologically defined criteria is also there, but they have included a new entity, which is MDS with fibrosis. And these are the changes with which we have to categorize our patients. So once the diagnosis is there, the next step is to determine their risk stratification. So our prognostic scoring system has also undergone a rapid and a new advancement, which is the development of IPSS molecular. This study has been recently published, where they have come up with 51 new genetic mutations which need to be tested in each of these MDS patients, and they have used the backbone of IPSS and IPSS-R and have included those genetic mutations in this. So to give you a brief idea, this is how this scoring system is going to look like. Since it is impossible to remember each one of them, they have an online calculator where you need to put up the entire data. It will give you, it will stratify the patient into 6 groups, which are low grade, very low grade, low grade, mild, low, moderately low risk, moderately high risk, and very high risk categories. And it will then calculate and give you the option of the disease transformation, overall survival, and leukemia-free survival. So when we look at the evolution of treatment, we know that over the years, very few drugs have been available for managing these patients. To begin with, we had erythropoietin. It was followed by iron overload, so we had to go for iron chelation. Then hypomethylating agents were made available, and then lenalidomide was approved for a small subset of patients having these are the treatment therapies which are available, which I mentioned just a few slides back in low-grade MDS. And this is the treatment algorithm which we follow, most of it. This is how we proceed in low-grade MDS, low risk. All right, so what is new for these patients? There are 3 exciting drugs which we should keep an eye on. One of them is the anti-TGF-beta, or the erythropoiesis maturing agents, luspatercept. It has been approved in the West, not available here, but hopefully will be available soon. Then we have got hypoxia-inducible factor, roxadustat, which is approved for treating anemia in chronic kidney disease, and is being tried in MDS patients as well. And then we have telomerase modulators, or imetelstat. We know that telomerase activity or hyperactivity gives rise to cellular destruction, so this drug targets at improving the cell survival. All right. Luspatercept, as you know, has recently been approved for low-risk MDS with more than 15% ring sideroblast following the results of the medalist trial. And based on this, the results showed that 38% of the patients were able to become transfusion independent. And the safety profile was also very good. So this drug was approved. Further trial is being on way, which is comparing its effect versus EPO, and also it is being used in combination with other drugs. The other molecule has a high toxicity level, but the results were same. All right. The hypoxia-inducible factor, roxadustat, again, trials, phase 3 randomized trials are being conducted to see its effect in low-risk MDS patient with minimal RBC requirement. The other drug, imetelstat, following the iMerge trial, has got good results because, again, initial studies showed that transfusion independence was seen in 37%, which is equal to what we saw with luspatercept. And on this basis, FDA has granted it a fast-track approval. All right, now coming to the high-risk MDS group, this is the group which is most challenging because we know that the only curative treatment is transplant, and since these patients are elderly, it's very difficult to go for transplant. So it is reserved for only select number of patients. The other treatment options available is the best option is to put them on clinical trials, which unfortunately are not available here. And then we have got low-dose chemotherapies or combination of dono and cytosar, CPX351. So what to look forward in high-risk MDS patients? These are the major groups, which is very difficult to comment on each one of them, so I'll discuss some selected ones. The new generation HMAs. Okay, right. This is just a diagram to let you know the targeted therapies that are being focused at different cellular levels. Okay. The new generation HMAs, the focus is on switching to oral HMAs. And out of them, Incovi, which is a decitabine oral preparation, has gotten FDA approval following the certain trial results, which showed pharmacokinetic equivalence with IV decitabine, which is a good achievement, and an overall response rate of 61% in these patients. The other drug, which is oral azacitidine, it showed transfusion independence in 31% patients, but though no improvement in overall survival was seen. The third drug has not yielded good results. Venetoclax, we have been treating patients. Venetoclax, as you know, has been approved for treating AML in elderly patients, along with HMAs and following the VILE-A trial, and is also being used and tried in clinical trials for high-risk MDS patients. Overall, it has shown very good results with ORR of 84%, complete remission seen in 40%. Another advantage is that the time to achieve complete remission is much short than what we see with HMAs. It's just 2.6 months. And another added advantage is that it is affected across a variety of mutations which we see in MDS patients. A Verona trial, a phase 3 trial, is on its way. Another interesting group which is targeted is the IDH. IDH, as you know, mutations in IDH, it alters the epigenetic regulation and cell differentiation is blocked. So there are two molecules which are being used. One is ENA and the other is IVO. ENA is an oral molecule, and because of its very good safety profile, is being considered as an off-label use in either alone or in combination as a frontline setting. So we may see this drug soon. The other one, IVO, was tried in elderly patient, and as you can see, the median age was 72 years and the overall response rate was 75%. And based on these findings, it also has been granted a breakthrough designation by FDA, and the study, IDOM study, which is a phase 3 trial, is ongoing. TP53 modifier. Okay, this is another drug, hasn't been named yet. It is APR 246. This again was evaluated in, as you can see, it was evaluated in a very high risk elderly population with complex karyotyping and who were unresponsive to standard therapy. Results are very heartening, with almost 70% overall response rate. And this is another drug which hopefully will be soon available. Now, some of the less successful drugs, FLT3 inhibitors, which are used successfully in AML with FLT3 inhibition, failed to impress. Similarly, some splicing modulators and histone modifiers like vorinostat, which initially showed good response but failed to deliver in the third phase trials. All right. Now, a few words about immunotherapies. This is a very exciting field of targeted therapy, because what immunotherapies do is that they enable our own immune system to fight against the tumor cells. There are two major groups. One is the CAR T cell therapy, which Dr. Munira will discuss soon. I won't touch upon it. The other one are the monoclonal antibodies, which are ADCs or antibody drug conjugates, like we have got brentuximab vedotin in Hodgkin lymphoma patient. Then we have got BiTEs, and we have got immune checkpoint inhibitors or ICIs. ICIs have been used successfully in solid tumors and has been tried in MDS patients as well. What they do is that they, there are certain checkpoint proteins which are expressed on the immune cells, which helps them to recognize self-proteins, and those which do not have the ligand are considered as foreign. Unfortunately, these tumor cells have the ability to provide a ligand which binds with these checkpoint proteins, helping them in escaping the immune response of the body. The first two drugs, nivolumab and ipilimumab, has been used in CA breast patients, and I believe in other solid tumors as well. And then we have got two more drugs, which is anti-CD47 and anti-TIM3, which is sabatolimab. All right. So the first two drugs in the initial trials have shown very good effect with an ORR of 71% in combination with AZA. The only drawback was the high incidence of immune-related adverse reactions because of immunotherapy. Magrolimab, which is anti-CD47, again has shown excellent result in the phase 1 trial with an ORR of 92%, and has again been granted a breakthrough therapy designation by the FDA. And further phase 3 trials by the name of enhanced trials are ongoing, comparing it with AZA versus AZA alone or with a placebo. Now lastly, we have got sabatolimab, again a novel ICI. The advantage of this particular immune checkpoint inhibitor is that it combines two specific receptors which are expressed on the blast cells and the malignant cells only. So it has a very targeted effect. It is not expressed on normal hematopoietic stem cells. So initial responses, early studies have shown a very high response of approximately 60%, and due to which a broad clinical group of trials by the name of Stimulus have begun, in which they are comparing this drug either alone or in combination in different in different types of MDS. Excuse me. All right, so this brings me to the end of my presentation. I would like to say that there are exciting times ahead of us. Maybe we won't be able to see these drugs, but hopefully our young residents will be able to manage patient much more better. And there are some very promising drugs to look forward to, especially for patients with high-risk MDS. Thank you so much. Any questions? If you ask me any question, thank you.
Thank you so much, Dr. Naila Raza. If we can take the questions in the panel discussion session. So thank you so much for enlightening us regarding the treatment options available in case of MDS, especially the novel drugs and the newer drugs. So moving ahead, we have Dr. Bushra Ehsan with us. She graduated from King Edward Medical University. Later on, she moved to Ireland, UK to pursue her specialist training in hematology and bone marrow transplant. She came back to Pakistan and joined Shaukat Khana Memorial Cancer Hospital in 2018 as consultant hematologist, and since then she has been affiliated with it. So please welcome Dr. Bushra Ehsan to talk about treatment options in indolent lymphoma.
Assalamu alaikum. It's a great pleasure to talk on the 43rd annual conference. I'll wait for the presentation. I have nothing to disclose and no conflict of interest. Okay. So the topic given to me was the current treatment options for indolent lymphomas. As you know, that indolent lymphomas comprise 1/3 of the non-Hodgkin's lymphoma. And although these are slow-growing tumors, but because of the relapsing remitting nature and also potential to transform into aggressive lymphomas, they can have a significant impact on the quality of life of the patient. So this diagram just tells the different types of indolent lymphomas, the most common being the follicular lymphoma and the CLL. Since it's not possible to discuss the current treatment options in all of them, so I take the liberty to talk about follicular lymphoma and CLL. So this is the general framework for follicular lymphoma. Once we have diagnosed the follicular lymphoma and done the staging and evaluation, we know that follicular lymphomas are very sensitive to chemotherapy, radiotherapy, and they can be asymptomatic. So if they are localized and there are no symptoms, just wait and watch, or you can give radiotherapy to a single site. If they're advanced but still indolent, then again it's reasonable to just wait and watch, or you can give a single agent rituximab. If it's an advanced follicular lymphoma with symptoms, then according to different criteria, whichever you like the GELF criteria, you start treatment. And the treatment modalities are chemoimmunotherapy. Now, which chemoimmunotherapies do you use? This slide nicely summarizes the different immunotherapy options that we have as a first line of treatment. The interesting thing is the comparison between the follicular and when later I do the CLL is that in the follicular lymphoma, the immunotherapy and radiotherapy combination remains the first line rather than the novel agents. So the first line treatment are combinations of bendamustine rituximab, or you can use obinutuzumab and bendamustine, R-CHOP or obinutuzumab CHOP, RCVP, OCVP, and then lenalidomide and rituximab called R-squared. And then followed by maintenance or consolidation, whatever you like to call it, with rituximab or obinutuzumab. So once the patient relapses, the second line options are the similar chemotherapy options. You can use an alternative regimen that you haven't used before, or you can use the one that you used before as well. And in addition to that, there are certain novel agents that we will see in the slides ahead. So this is the slide which shows all the trials over the time that have guided us over time what to treat the follicular lymphoma with. The first two trials, sorry, it's gone back. Let me go back. So the first two trials, the STILL trial and the BRIGHT trial, they are the one that compared the bendamustine rituximab combination with the R-CHOP and RCVP. And the conclusion was that the combination of bendamustine with the rituximab gives you a better overall treatment response, and hence that is a preferred choice as a first-line treatment. And I'm sure most of you will be using it as a first line in the follicular lymphoma. The Gallium trial, that was an interesting trial, and that gave us an option of using obinutuzumab instead of rituximab because it showed more efficacy. However, the side effect profiles, as you know, are still there, but again, it's at a physician discretion to use bendamustine rituximab or obinutuzumab bendamustine combination. And I'm sure many of you, if you have your hands available on obinutuzumab, you use obinutuzumab and bendamustine combination. The last trial, the relevance trial that shows here, this was a sort of an effort to take chemotherapy out and just give Revlimid and rituximab combination, but it did not show superiority of using Revlimid and rituximab as a first-line agent in the follicular lymphoma. However, in a subset of patients, it's still a choice that you can still use for patients you want to prevent hematological toxicity, older patients, but it has more role in the relapse refractory setting. So this just summarizes the current chemoimmunotherapy options that we use, and they're still valid. So the next slide, it moved by 2. So once you've given the treatment with bendamustine rituximab or obinutuzumab bendamustine, I'm sure most of you believe in the maintenance or consolidation, whatever you want to call it, with the rituximab for 2 years. This was the landmark trial, the PRIMA trial, that showed the progression-free survival, which they looked for 12 years post the maintenance, and it showed that there was you can see there is a significant improvement in progression-free survival in the patients who are on maintenance post their initial first line of treatment. There is no significant overall survival benefit, but in indolent lymphomas, where the quality of life is affected, progression-free survival is an important parameter. Okay, so in addition to obinutuzumab and R2, what other agents came along? We have PI3K inhibitors, idelalisib, copanalisib, duolisib, and umbralisib. The ones that are crossed off, they're not available anymore, and we'll talk about them in the later slides. Copanalisib is the only one that has this is available and is licensed for use. And then we have the CAR T cells, which I leave Dr. Munira Musaji to talk about. So in addition to this, what other agents are currently being used? As we mentioned before, the combination of rituximab and Revlimid. not so beneficial in the first-line setting, but in the relapse refractory setting of indolent follicular lymphoma, when rituximab and lenalidomide combination were used in comparison with rituximab alone, the results were quite promising. Significant progression-free survival benefit, significant overall survival benefit. So it remains a good modality for relapse refractory patients, particularly the older ones where you do not want the hematological toxicities. PI3K inhibitors. So the only PI3K inhibitor that is available or is licensed now is the copanlisib, particularly during the COVID time period. Idelalisib, duvelisib, and umbralisib have gone out of the market, and it was said that probably the trials would have never completed, and so the manufacturers took them off. Umbralisib had its side effect profile, which did not go well with the trial, and hence that is not considered worth using. So we have copanlisib available for relapse refractory settings. Now, this is the new kid on the block, tazemetostat. Here you can see in this diagram that EZH2 is a regulator in the germinal center of the B cells. It regulates the development of the germinal naive B cells into the mature cells. However, if there's a mutation there, or there is an upregulation of it, or this can result in the neoplastic transformation rather than normal maturation. This EZH2 inhibitor, tazemetostat, is a selective oral first-in-class inhibitor, and this has been tried, and this was published in the Lancet in 2020. This was an open-label multi-center trial where all the patients with follicular lymphoma, their tissues were biopsied and they were tested for EZH2 mutation. So there were half and half almost of EZ mutant and EZ wild type follicular lymphoma patients, and tazemetostat was used. There was a much better overall response rate, about 69% in the mutant group, but still there was a good enough, about 35% in the wild type. And based on that, tazemetostat is a very good option in the patients' follicular lymphoma, particularly those that have the mutant EZH2 type. This is, so as we are talking about the targeted agents, where do the BTK inhibitors fit in the follicular lymphoma management? This is a trial, the Rosewood trial, and this was only recently published, where they compared zanubrutinib obinutuzumab combination versus obinutuzumab on its own, and the results were better progression-free survival and better overall survival. So to summarize, the current, so CAR-T is another option, which I think is beyond the scope of this presentation, so I won't touch on that. The summary of the current treatment options for follicular lymphoma: first-line options, chemoimmunotherapy, rituximab or obinutuzumab with the chemo. You can add lenalidomide to a subset of patients if you like, and then followed by maintenance once the chemo is finished. What about the second line and beyond? You can add any of these options: EZH2 inhibitors, copanlisib, zanubrutinib combination, and finally the CAR-T cells. So when we move on to the CLL, there's a paradigm shift. Unlike in follicular, where chemoimmunotherapy remains the first line of treatment, here the chemoimmunotherapy has taken the back stage, it's gone to the back burner, while the targeted therapies have come to the front line. So, but still, chemotherapy is being used, particularly in our settings where we do not have our hands on all the new targeted therapies because of cost restraints or availability, etc. We still use the chemotherapy regimens, FCR, BR, or chlorambucil, and we only if we have TP53 mutation, then is when we consider the novel agents. However, in the Western countries, and many, if you have them available here, depending on your institute, the novel target therapies are being used in combination or as a monotherapy exclusively. So those are the venetoclax and ibrutinib group. So this is a nice diagram. As you can see, fludarabine, bendamustine, chlorambucil, their target used to be on the cancer center cells, and they would destroy the cancer cell. At the same time, they cause toxicities. However, the targeted therapies and the monoclonal antibodies, they act only at the targets and hence with lesser toxicity. So PI3K inhibitors, then we have BTK inhibitors, we have BCL2 inhibitors, and we have the monoclonal antibodies acting on the surface. So the current management of the CLL now would be that if you have this availability, then venetoclax and obinutuzumab is the first line, or you can use acalabrutinib and plus minus obinutuzumab. Once the patient relapses, then you can use it vice versa. The regimen that you haven't used before, you can use that now. But what about the chemotherapy options? Well, this is valid for Western countries, or particularly in the US, where targeted therapy have exclusively taken the first line, but we still have FCR, BR, and chlorambucil available. Now, what led to this change are these trials. Important to mention E1912 trial, which compared the treatment of treatment-naive CLL patients with ibrutinib and rituximab, comparison with FCR. So the results of this trial showed the progression-free survival improved with the patients who were treated with ibrutinib and rituximab combination. And this is particularly true in the B, the graph which is labeled B, the unmutated immunoglobulin heavy chain group, and not so in the mutated immunoglobulin heavy chain group. So still in the patients who have immunoglobulin mutated chains, FCR is still a valid option for that. Otherwise, for the unmutated group, the best option is ibrutinib and rituximab combination. Again, overall survival, there's improved overall survival in the patients in the ibrutinib rituximab group. Two more trials that favor the same thing is the Resonate trial and the Alliance trial. In both of them, you can see ibrutinib tops. Here it is compared with ibrutinib, is compared with chlorambucil, and in the Alliance it is also compared with, I think, combination there with the bendamustine and rituximab. So based on these three trials, E1912, the Resonate, the Alliance, ibrutinib, and rituximab combination is the first line for the CLL. CLL14 trial. Now this compared the use of venetoclax, as it was just mentioned, BCL2 inhibitor, and this has worked wonders in AML and MDS, and it was, in fact, the CLL was one of the first one where the BCL2 inhibitor was being used extensively, and the results are quite mature now. They used venetoclax and obinutuzumab combination in previously untreated CLL, 6 cycles followed by 6 cycles of venetoclax. So this was a fixed duration treatment, and this was compared with chlorambucil, obinutuzumab, 6 cycles followed by chlorambucil. The primary endpoints were progression-free survival. There were certain other things, results found in the secondary endpoints, but we will not talk about them. That will be too detailed. So the result of CLL14 trial show venetoclax and obinutuzumab combinations give you a much better progression-free survival than the chlorambucil obinutuzumab. I'm sure all of you who treat CLL and who have used the chemotherapy options would argue that all these trials compare chlorambucil, which is the last drug that you would consider, and they do not compare it with FCR or BR, but I'm sure with the subsequent trials, they have extrapolated that information into that as well. So CLL14 results are that fixed duration venetoclax and obinutuzumab, this provides a superior outcome compared with chlorambucil and obinutuzumab across all groups, including immunoglobulin heavy chain mutated or unmutated. Overall survival has not been observed yet, but again, with the indolent lymphomas, progression-free survival is a very important parameter, and which eventually translates into the overall survival. Elevate trial, it's a similar. First, we talked about the ibrutinib and rituximab, then we talked about the venetoclax and obinutuzumab. Now this third trial, the Elevate trial, this compared acalabrutinib obinutuzumab combination with acalabrutinib alone and obinutuzumab plus chlorambucil combination. The results, again, the combination of acalabrutinib and obinutuzumab tops, and hence the conclusions are that acalabrutinib and obinutuzumab monotherapy both significantly improve progression-free survival versus chemotherapy option. So then again, some people use acalabrutinib with or without G, and this also has improved progression-free survival, and this would be more so in patients who have a high risk or even low risk disease characteristics. So this was for the first line CLLs. Now, what about the relapsed CLL? For the relapsed CLL patient, the Murano study is the basis now, where the patients who've had treatment before, and whether they're 17p deletion or not, they were given venetoclax and rituximab combination, and how they did was they ramped up the dose of venetoclax starting from 20 and going all the way up to 400 milligrams, and this was after the 6 cycles of venetoclax rituximab, venetoclax monotherapy was continued for a maximum of 2 years. This was compared to bendamustine rituximab. And at the end of treatment, when they have compared the progression-free survival, so up till 57 months, I think, so there has been a significant improvement in the progression-free survival. So the Murano conclusion for the relapsed CLL is that after a median of 48 months follow-up, progression-free survival and overall survival benefits were sustained with a time-limited venetoclax rituximab compared with the bendamustine rituximab. So the overall conclusion for CLL, for the front line, you have ibrutinib or acalabrutinib plus minus obinutuzumab, and this can be for fixed duration of treatment. On relapse, you can use venetoclax. If they're venetoclax naive, you can use venetoclax naive venetoclax combinations. And if they have been exposed to that, then you can use the BTKI inhibitors. So this was just the 2 most common indolent lymphomas that I talked about. And a little difference, though the targeted therapies have made their way both in follicular and CLL, but in a slightly different manner. We hope to use this as first line. I don't know how many of you are using them as first line. Venetoclax, I'm sure many of, I think probably in Islamabad, there are Pindi people are using, but we at the moment are still using it in a relapse setting. Oh, ibrutinib and rituximab combination. Okay, so that is it. Thank you.
Thank you so much, Dr. Bushra Ehsan, for enlightening us with valuable information regarding treatment options in lymphoma, especially the advanced treatment options in follicular and chronic lymphocytic leukemia. Before moving on to the panel discussion, I would request our team, if the technical issues have resolved, and we can play Dr. Munira Musaji's presentation.
And I'm currently also the director. Good afternoon. I want to begin by thanking the organizers of giving me the invitation to talk to you today about CAR T cells. My name is Munira Musaji. I am a clinical associate professor at the section head of medical oncology at the Aachen University Hospital, and I'm currently also the director of the stem cell transplant program. So I'm going to begin this this discussion by really going through first the history of the development of the CAR T cells, as well as how it has translated into our clinical practice today. So starting with the evolution of adoptive cellular therapy, it dates back way in when allogeneic stem cell transplants really came about in the 1950s and the 1960s. That's when we learned about the role that T cells have to play in the GVL and the graft versus host disease effect, leading to identification of the B cells, T cells. From then on, a lot of time went into the bench work, resulting in identification of T cell restriction, identification of T cell receptors, How does the DLI work? Development of the chimeric T cell receptor in the late 80s by the Weizmann Institute in Israel. All of this bench work then eventually led to the formation of the first generation CAR T cell by the Weizmann Institute. Now in the 2000s, there has been further identification of molecules, further research has led to understanding of how the CAR T cells really work, identification of the co-stimulatory domain. I'm going to talk about that in a little bit. And now we are in the phase of multiple products that are approved and more indications for CAR T cells. So the story begins with identification of ideal tumor antigen. So really, what is that? That is an antigen which is expressed in the tumor cell population, and it should be ideally restricted to the tumor cells so that you don't really harm the other tissues. It should be on the cell surface, so it is identifiable and targetable, and it should be a marker which is required for tumor cell or survival. Otherwise, you're not really going to get cell death. So CD19 has been identified as the ideal tumor antigen. The reason why it is because it's restricted to B cells. And it is, and as you can see, CD19 is expressed through the entire phase of maturation of B cells till it becomes mature enough to be the peripheral plasma cells. CD19 is not expressed in the pluripotent bone marrow stem cells. That is, therefore, you can hypothesize that the feared complication of bone marrow aplasia would be a lot less in patients who are treated with CD19 CAR T cells. CD19 is also expressed in or is expressed on the surface of most of the B cell malignancies, and it is directly related to tumor growth, and therefore inhibition of CD19 would result in tumor that is dying. So some of the earlier work which was done by the Weizmann Institute, as well followed by the Carl June's lab in University of Pennsylvania. They reported some of the earlier trials. This is a paper in Nature Medicine in which they were able to transduce CD3 zeta on the CAR T, on the T cells, and they were able to show in the flow cytometry showing lysis that after transduction of the CD3 zeta on the T cell, they were able to show CD19 lysis. In further, this led to, so the next step is that, well, can you expand this T cell product? And the answer is yes. Using interleukin 15, they were able to show good and sustained expansion of the T cell product. In the in vivo models, the C graph is looking at a mature lymphoma cell line, which is a Raji cell line. When treated with a CAR T, they're able to show lysis of the Raji cells in the in vivo model, and which translates into improved survival. However, this was when they looked at the NAM6 cell line, which is an ALL cell line, they were able to show death, but it was not sustained. That led to the identification of the co-stimulatory molecule, and if they were able to co-stimulate using CD80, they were able to show cell death, and this was a sustained improvement in survival. So now we do know that for effective T cell stimulation, you need two signals. One is through the T cell receptor, and the second one is through a co-stimulatory receptor, which is either a CD28 or a 41BB or an OX40 for B cell lysis. And in the absence of this second signal, your T cells will either become unresponsive or undergo cell death by apoptosis. So over the decades, CAR T cells has really developed over time. So the first generation CAR T cells, as I said earlier, was developed in the late 80s, early 90s by the group in Israel, followed by the second generation and the third generation CAR T cells. The second generation added one co-stimulatory domain. The third generation added to, resulting in more effective. And now we are currently in the phase of development of the 4th generation, which includes addition of various cytokines. So I'm going to restrict my talk on the CD19 directed CAR T cells, as most of the literature has come in from the CD19 CAR T groups. So in summary, this is a graphical representation of what it looks like. You have CD19 binding domain right here, the fusion protein, and the signaling molecule, which contains the T cell receptor domain as well as the co-stimulatory domain, which is transduced into the CAR T using a viral vector. And ideally, it should be recognizing the tumor cells with the binding domain, resulting in an activation of the T cells, causing cell death. So here this is what the patient journey looks like. So the first step is leukapheresis. The white cells of the patients are collected, which is very similar to how we would collect mononuclear cells for a DLI. Then the cells are transported to the manufacturing facility, and in the facility, it really undergoes 3 processes. The first step is to isolate the T cells and activate them. The second is to transduce them by a viral vector. And then once the cells are transduced, then the T cells need to expand for it to be therapeutically effective, followed by infusion of the same CAR T cells into the patient, and then you just wait for activity and for them to do their job, that is kill the tumor. The median time usually for manufacturing is about a month. Typically, the patients will need some kind of lymphodepletion and a bridging therapy, and I'll talk about that in a little bit. So when you talk about the lymphodepletion, it's usually for a 5-day protocol, very similar to a protocol that we would use for non-myeloablative conditioning. Followed by that, it could be patients usually require hospitalizations because almost always they will develop some acute side effects. And then typically by day 30, they are requested to remain within the radius of the treating facility, and then they go on to long-term management. So the key patient and disease factors that determine candidacy for the CAR T cells, very quickly I'm going to go through these. And the first one is the indication. So does that patient fit the FDA approval for the product? Second is the kinetic of the disease. Do you have the time to leukapherese a patient, and does the disease, and do think as a clinician the disease will remain stable till the time you're able to get the CAR T cells back to be infused? This is an expensive therapy, so is there any other therapy that can be considered? What about immediate therapy, immediate treatment prior to this therapy? This definitely affects the quality and the quantity of the T cells that can be leukapheresed, and therefore affects the CAR T cell product in the end. The patient should be ideally should not have an active infection, because infections increases risks of and really should not have very active comorbidities. These are very similar to what we use for allogeneic transplant evaluations. Most of the patients will need bridging therapy, and the aim of bridging therapy is twofold. One is to allow the patient to try and keep the disease in control by the time the CAR T cell products go to the manufacturing facility, come back. Second is, if you have less disease, theoretically you will limit CRS and ICANS. Limit CRS and ICANS, and some patients and some patients, you might have CR with bridging therapy alone. But you have to remember is the bridging therapy needs to stop prior to hematological recovery, and hematological recovery needs to happen prior to lymphodepletion, so you limit complications. So lymphodepletion is really, as I said before, very similar to non-myeloablative conditioning protocols using fludarabine and cyclophosphamide. A thing to note is there is fludarabine shortage worldwide. Bendamustine has been used, and there are clinical studies for bendamustine. Just a caveat, lymphodepletion can be omitted if a patient has a very low WBC count within 7 days of CAR T cell therapy. So really, this is not a single person. It takes a village to get a CAR T cell therapy program off the ground. And really what you need is patients who are physicians who are referring patients for consultation. So you need to have a communication with other physicians in your community and who are going to be sending patients to you. You should have a unit which is well versed in cellular therapy. Almost all allogeneic stem cell transplant programs will have this facility for collection, for infusion, and obviously for bridging therapy. Then you would need to have the hospital and taken care of. Physicians who have trained CAR T cell, who are trained in CAR T cells, who have CAR T cell experience, to really recognize the different complications in a timely fashion to reduce mortality. And then obviously you have all the regulatory authorities come in. So currently the CAR T cell products that are approved are listed right here. You have the CD19 therapies, and I'm going to go into a little bit of detail in that in a little bit. Axicell for diffuse large B-cell lymphoma and follicular lymphoma, brexocaptogene for relapse mantle cell lymphoma, and Lysocell for large B-cell lymphomas, and Tisacell for ALL and DLBCL. And then you have the BCMA directed for myeloma, but please concentrate on the cost. These are very expensive therapies, approaching close to $400,000 to $450,000, with $150,000, and this does not really include complications. So Tisacell was the first kit in this group to achieve to be reported, and this was a seminal paper published in NEJM in 2018, which looked at Tisacell given to patients with relapsed refractory ALL. And in this very difficult to treat patient population, Tisacell was able to show an overall survival benefit and in an event-free survival which was not reached. This was unheard of in the hematological community, and this really jump-started CAR T cells. Going to just concentrate the next bit of my talk on the non-Hodgkin's lymphoma products, which are the most commonly prescribed indications in adults. And we have 4 products, 3 for DLBCL and large B-cell and follicular lymphoma, 1 for relapsed refractory mantle cell lymphoma. The constructs are given right here, along with the lymphodepletion protocols. And so these were the pivotal trials looking at these products. Just concentrate on the CR rates in this multiple relapse refractory group. They were able to achieve a 50% chance of CR, almost in 18 months, 50% overall survival. The CRS and the neurotoxicity between Tisacell and Axicell is about similar. Lysocell, which is a much newer product, has lower cytotoxicities. When compared with the standard of care, so this is a retrospective analysis which looked at the ZUMA-1, which is Axicell, versus the standard of care treatment for refractory DLBCL. ZUMA-1 was able to show an overall survival benefit. But will CD19 T cell therapy replace autologous stem cell transplant? And there were 3 trials which looked at that: the ZUMA-7, Belinda, and Transform, which looked at this question, and they were discussed at ASH last year. I'm going to talk about 2 of these: the Belinda study, which is Tisacell, and ZUMA-7, which is Axicell. If you all remember, both of these studies were published together in NEGM in I think 2 or 3 months ago, and they have different clinical trial design. Most of these patients were leukapheresed, and then they received some optional bridging therapy and lymphodepletion. Most of the patients received that, and then the other arm was standard of care, followed by week 6 PET scan, and then a T cell infusion. And the patient in the standard of care arm then continued to achieve that chemotherapy, and then they had another evaluation at week 12. Zuma 7 was a much simpler trial design. So these were patients, if they fit into the eligibility criteria, about 350 of those were randomized to axi-cel versus standard of care. And if you were in a CR or PR, you would go into a autologous stem cell transplant, which is, again, what we would do. In the Zuma 7 study, patients only were allowed to receive corticosteroids as bridging therapy. This is important to note because it really affected the results. So the Belinda study was a negative study. It did not show any improvement. Zuma 7, on the other hand, showed a marked improvement. Now, this difference is really due to the two different trial designs. Because of the use of bridging therapy, there were delays in the CAR T cells being given. There were some patients who responded to the bridging therapy alone. That could have affected the numbers. Since Zuma 7, only corticosteroids were allowed and patients were randomized to receive CAR T cells immediately, they were able to receive the products much faster, and this probably resulted in the improved event-free survival. So with regards to predictors of response of toxicity, again, you want to take this patient to difficult and a very expensive treatment protocol. You want to make sure you pick your patient right. So those which have a low tumor burden, who have absence of medical comorbidities, who ideally do not need a bridging therapy, meaning their disease is relatively stable. When you're talking about CAR T cells, a higher number of CAR T cells, peak to tumor burden ratio is usually what is warranted. And then you have a tumor which has a good phenotype, like high TILs, lack of MYC overexpression. That would be the best kind of patient. Again, you want to also predict toxicity, and again, in the pre-treatment, the higher tumor burden, higher toxicity. In the post-treatment, a higher peak CAR T cell level and cytokine levels, a higher rate of toxicity. So the toxicities, apart from the bone marrow hypoplasia and infections, the two ones to talk about are the acute toxicities, which are very classical of the CAR T cells, which are cytokine release syndrome, and ICANS, which is immune effector associated toxicity. The good thing is that these are self-limiting. They usually occur, for example, the CAR T cells usually occur in the first 2 to 3 days, and the duration is 5 to 7 days. Immune effector is usually typical onset in the first week, and duration is about 2 weeks. And it can be mild, grade 1, grade 2, or it can be severe, which can also lead to death and morbidity. So there is some difference in the rates of the CRS and ICANS, as you can see with regards to, and if you just concentrate on these 3 trials, the T-cell has got a lower rate of grade 3 CRS and neurotoxicity as compared to the axi-cel. The Zuma, the lysocell has the lowest. The management of the CAR T cells is usually includes very good supportive care, early recognition for both corticosteroids form the backbone of the treatment of both of these syndromes. In case of CAR T cells, you really should have tocilizumab available, and then if it is refractory, then IL-1 anakinra is usually used. The delayed toxicities are 2, prolonged cytopenias and B-cell aplasia, as you would imagine, because you are really depleting the CD19 positive cells. So you have B-cell aplasia, hypogammaglobulinemia, so you might need frequent immunoglobulin infusions. So the last 2 slides, I really want to talk about where we are in the developing world and what the global trends are. And so this is a very sobering slide. So there are currently 483 trials which are ongoing, and out of which 243 are actively recruiting. But the bulk of the recruitment and the trials are happening either in North America, mostly in the United States, and in China. Our neighbors, India, has one trial which is open. And Saudi Arabia and the Middle East have a couple of trials, but we are nowhere on this map right now. So really, what is the possible solutions to mitigate the challenges of global access to CAR T cells? One is, so really we're going to divide this into two. One is the key thing is manufacturing and supply chain. The cost is much higher when you are sending it to a facility. So maybe developing in-house CAR T product. Some universities in the US are able to do that. I think India is developing their own product as well. Logistics and manufacturing and time delays really play into the cost. Again, heterogeneity within the products. So, I mean, it's not one size fits all. We really have to pick the right product for the right patient. The second is the biological challenges. One is antigen escape. So you can have, you kill the CD19 and then you have the ALL come back, which is CD19 negative. So you have an immune escape, understanding immunogenicity, and then the big part of the toxicities and management of the toxicities and the drugs that are available. So I'm going to stop right here, and thank you so much for your attention, and I'd be happy to take questions at the Q&A session.
So that was a very interesting talk on such an innovative topic, and I hope that we all have gained much information from that. Moving ahead to answer any of your burning questions and also share insights and views regarding hematopoietic stem cell transplant, neoplasms, and also their treatment, especially the advanced treatment options. We have a panel of experts, including Dr. Tariq Sati. He is affiliated with Shifa International Hospital as a consultant hematologist and bone marrow transplant specialist. We also have Dr. Rahil Iftikhar. He is affiliated with National Institute of Blood and Marrow Transplant as consultant hematologist. Along with that, we also have Dr. Asad Abbasi. He is working as a consultant hematologist at Armed Forces Institute of Pathologists. So if we can have them on the Zoom link. All right, so due to some technical issues and the unavailability, we don't have the available panel, but if you have any questions, we have our chair and co-chair, Dr. Salman, Dr. Usman, and also the speakers. If any one of you has any question, then please go ahead.
I understand that this is probably the most difficult session of any conference. Post-lunch session is the most horrible session in any conference, and especially in Pakistan, when we have this type of food to eat, and then you sit down in a cool atmosphere, and the speaker, and it's like a luri being given by the speaker. So, having said that, it was really, the talks were really interesting, and we heard, I think, the recent advances in hematology as well. So those were exciting talks. It's unfortunate that we don't have uninvited people for the panel discussion, but the speakers are here. You can ask questions to most of them are here. In fact, all the speakers are here except Munir. मेरी तो आवाज़ बहुत so and General Parvez has left, and in fact to start with, if General Parvez was here, I always talk about the dilemma between the West and the East when we talk about transplantation. It's still, although General Parvez showed us the cost estimates of transplant in Pakistan as compared to India and the Western countries. It's still the lowest, but nevertheless it's still very high if we take the cost of transplant into consideration, whatever it is in Pakistan, about 3.5 to 4.5 million rupees. So the dilemma is that in the West, the cost is not that much of constraint because it's not out of pocket expense, and then, but unfortunately there are fewer transplant curable disorders, though the resources are there, but the transplant curable disorders are not there. And when we talk about our part of the world, there are a number of transplant curable disorders like thalassemia and neoplastic anemia, but the resources are not there. So it's so bad. And then so a lot of things to talk about out of that presentation, but I want the participants, if you have questions to the speakers. Exactly. Yeah. So if cost is not a constraint, so just imagine the number of people, the number of patients whom we can cure with transplant if cost is not a constraint. So many people die of those disorders just because of the lack of resources. Exactly. So now if you have questions to the speakers. Yes.
I'm asking a very basic question because we have a lot of residents and trainees over here. My question is, in one of the slides, Dr. Parvez showed that we can do the cost reduction based on infrastructure. So my question is, like, why there is a compromise, or is there a we have to have less infrastructure needed for bone marrow transplant compared to the developing countries? Our patients are more resistant to the infections or whatever. How can we reduce the cost on infrastructure? My understanding was that a typical environment is required for these patients, and that has to be it, like for all the patients.
Yeah, I agree. In fact, General Perez also showed a slide of compromising on the cost at the cost of quality. So you can't sort of compromise more than a certain limit, because then you will start compromising on quality. For example, you start using, for example, oral medications rather than IV medications, or you get rid of the environment, the HEPA filtration. For example, the purpose-built transplant unit, because many centers in the West do not have transplant setups like ours, basically, because of the risk of infections, etc. in our country. So yes, the cost of the drugs and the setup, etc., but then it would have to be balanced with the not compromising on the quality of care. That can't be, that trial cannot be done. Because I don't think you should compromise on the quality of care, and I still knowing that it's an expensive procedure, etc. But then when you are going for a potentially curable transplant, for potentially a curable procedure, I don't think beyond a certain limit you should try to compromise on the quality just for the sake of reducing the cost.
Thank you. If you compromise the quality, then the outcome is affected always. And we have always seen that when we compromise the quality, if it costs to cut the cost, we always have to take a balance.
because many times if you see that the outcome is good, you may compromise some quality. But if the outcome is not good, it's not always feasible to cut the cost. It's because in our part of the world, patients usually die of infections. Infection is very common in Pakistan, and we have to take care of all these things because yes, management. So we usually have to keep a balance. We can't compromise the quality.
Actually, only 20% transplant patient are smooth sailor. 80% develop some sort of complication, irrespective of what are the underlying diseases, excluding auto transplants. Allo transplant is a big challenge, no doubt. So only 20% to begin with. So for the remaining 80%, yes, sometimes, all the time, one of the most important prognostic factor in Pakistan, even after getting the cost, is the post-transplant care, and again that going to compromise. CMB कराना weekly नहीं करा पाते. Say for example 25,000 per weekly, वो cost कहाँ से है? First 100 days की है, and 50% patient develop ultimately CMB, and 50% graft-versus-host disease. And drug costs, say for example, Jakavi and others, and all the things, they are all very costly. So transplant is a big issue. Dr. Bushra, 2 questions.
The story begins after transplant. The main still our cost is low as compared to the other countries, you can see.
No, that is again a misnomer sort of thing. Problem is that their monthly earning, say for example, to say a person belong to a poverty group in America, at least who earn less than 12,000 pounds per annum. That's mean $1,000 per month से अगर नीचे आएगा, then you can say that. So it's a different world scenario. Here is, 15,000, 20,000, there's a different thing. So here transplant is a costly procedure, there is no doubt, up to 5 million, even when compared to USA. Dr. Bushra, just 2 questions. One is that just tell about the low-grade lymphomas you say. Although rare, but sometimes we see stage 1 disease, say for example in follicular lymphoma 1. So what is your approach in that case? Stage 1. Okay. Yes. 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 This is important because we all the time say that low-grade lymphomas are incurable, but in that setting, we can cure these patients, and a good number of patients can be cured in a very early stages, although rare. But this is one aspect. Number 2, there are many prognostic biomarkers in the CLA. Okay. Sometimes we do IGVH mutated versus unmutated, and nowadays this is clear cut 3 mutations, TP53 versus 11q versus 13q, and they broadly divide this. So where do you place this in that scenario, both these systems? One is with FISH analysis as compared to this mutated versus unmutated, because all the studies which you have shown, they just identify on the basis of mutation analysis. They didn't identify these on the basis of this FISH analysis.
Well, TP53, we are doing it on FISH as well, and I think almost everybody does it on FISH, the TP53 mutation. On the peripheral blood, when we send for flow for CLL, we send for TP53 mutation as well. And definitely all of us know TP53 is a bad mutation to have in all sort of hematological malignancies. And in that case, from the upfront, you know that they're not going to
respond to chemotherapy, or they're going to do really bad and relapse and progress. So to them, definitely we offer ibrutinib and venetoclax, though they have to wait for weeks and weeks for that to be imported and all that in our hospital. Immunoglobulin heavy chain mutation, this they have to get it done privately because it's not offered to everyone on support. So I don't know in your hospitals whether you were checking immunoglobulin heavy chain.
No.
Yeah, but it is.
But that is very important.
Yes.
Approximately 15% patient at one time CLL is again said that it is an incurable. Now 15% patient in his studies, those who have mutated, now said to be cured.
Yes, that's why in the trial, the E1912 trial, when they compared the response, they have divided the groups in those that are mutated and unmutated, and the response in unmutated is obviously much better, and the mutated one is not that significant. Therefore, they do conclude that for the mutated one, you can still have FCR or BR or whichever you're using. So if you're not checking it, so we are not at a complete loss if you're giving them chemotherapy. But obviously, if it's an unmutated one, then we are that is the group that we don't know, and that we only will find out once they do not respond or if you check.
Last comment is that I hope in next few years this CAR-T will be out of our business, because so much influx of immunoglobulin, monoclonal antibodies, and even I don't know, but in next 5 years time, nowadays one of the most common indication of auto transplant is multiple myeloma, and there is an antibody now in, and that will now is the question that either patient need auto transplant or not.
Yes.
So I believe with the passage of time,
transplant,
especially in the context of gene therapy in thalassemia, and lupraticept too, and for myeloma, and say for example in aplastic anemia is another immunosuppressive which is work very well, then I believe in next 5 to 10 years time we will all these transplant indication out of order.
Yes, hopefully.
So thank you so much. On that note, we end our panel discussion. Now, as a gesture of thanks, we would like to present shields to our respected speakers. To do the honors, I would like to invite Dr. Salman Adil and Dr. Usman Sheikh. Dr. Usman Sheikh. So please welcome Dr. Naila Raza to accept the shield. Thank you, Dr. Naila. Thank you, Dr. Salman. Now, Dr. Usman, please welcome Dr. Bushra Ehsan. Dr. Parvez has already left, and for the speakers who were not physically present here, we will just mail their shields to them and also to the panel experts. Moving on to the short talks, I would like to invite Dr. Neelam Mansoor. She's affiliated with Indus Hospital Blood Center, Karachi. Please welcome Dr. Neelam Mansoor to present her paper. And please, there's a time limit for all the speakers of 7 minutes, so kindly restrict to that. Thank you.
It was written 10 minutes on the instruction, so I will try. So, the topic of my today's talk is childhood with lymphoblastic leukemia and integrating the role of cytogenetics with induction outcome. So, I have nothing to declare. The outline of my today's presentation is a brief background, methods, and a detailed description of results. So, this is a brief overview. As we all know that in recent years, prolific growth has been seen in understanding of genetic profile of hematological malignancies. Malignant hematology is a heterogeneous group of disorders which are driven by genetic mutations and epigenetic alterations. And as we know that these mutations are the basis of all the classifications nowadays, and it plays a significant role in disease prognosis and therapeutic management as well. So what is the purpose of cytogenetic studies in hematological neoplasms? It is important in diagnosis, in risk stratification, in selection of proper treatment, and to predict the outcome of the disorders. So here is a brief background where you know that molecular categorization of malignancies based on cytogenetic aberrations is an old concept in oncology. The significance of cytogenetics still play a significant role in diagnosis and prognosis of these neoplasms, particularly in B lymphoblastic leukemia. So similarly, the post-induction bone marrow assessment is still possesses a great clinical importance in the prediction of outcome in BLL, especially in low middle income countries where advanced techniques like flow cytometry, like FISH, like PCR, these facilities are not widely available. So the recurrent translocations together with the loss and gain of gross genetic material can easily be identified using conventional karyotyping. Further, the use of FISH allows the identification of cryptic chromosomal rearrangements. Post-induction status is one of the most imperative markers which determine the early outcome of childhood BLL. The objective of the study was to determine the frequency of cytogenetic aberrations in childhood BLL and its association department of the Indus Hospital. The data included was from October 2020 to October 2021. And the sample size was 242 patients, newly diagnosed cases of BLL, age range from 1 to 17 years. All patients were treated with a modified COG protocol, and the risk stratification was based on NCI risk stratification, that is age and TLC count. And prophase was assessed on the basis of peripheral blood on day 8. So FISH is performed for MLL gene rearrangement, BCR ABL1 and ETV6. While karyotype was performed by G-bending. Bone marrow aspirates collected on day 35 of the post-induction treatment and was assessed morphologically for the remission status. The remission was defined as the presence of less than 5% blast in the bone marrow aspirate. So these are the definitions of how we classified the cytogenetic abnormalities in this study. There are numerical hyperdiploidy with a model number of 47 to 57, hyploidy and hypoploidy, and similarly the structural abnormalities were categorized as non-random, random and complex karyotype. So in results you can see that out of 242 cases, 4 were excluded due to culture failure, and total 238 patients were included with a median age of 6 years. Hyperleukocytosis was observed in 27% of the patients, and CNS2 status, that is the presence of blast in CSF, was seen in 7.56% of the total patients in the study. Most of the patients, like 95%, showed good prophase response, while in NCI risk category, high risk and standard risk were almost equal. So this is the gender distribution as per cytogenetic categories, and here you can see in all subgroups there was male predominance with the male to female ratio of 1.6:1. In overall study, out of 238 patients, abnormal karyotype was observed in 61% of the cases. These are the number of cases. So these are the number of cases as per cytogenetic abnormalities. Here you can see the most common type was hyperdiploidy and the least common was monosomy 7. This is the comparison of prognostic factors in the studied cohort with and without remission, and none of the prognostic factors show any significant difference with these parameters. So in total patients, there was 8.4% that were positive for ETV6 RUNX1, 7.5% for BCR-ABL, and 2.5% for MLL gene rearrangement. The significant difference was found with translocation 922 and hyperleukocytosis and prophase response as well. Chromosome 11, like MLL gene rearrangement, also showed significant difference with hyperleukocytosis, and hyperdiploidy and non-random structural abnormalities showed significant association with NCI risk grouping. Remission status was reported in 211, while in 27 cases, day 35 bone marrow examination could not be performed due to abandonment or due to any early death. So there is no significant difference seen between the remission status and any cytogenetic abnormalities. In this slide, there is a concordance between fish and conventional cytogenetics, and here you can see that for BCR-ABL1 by fish and karyotype, there was 61% cases which showed concordance, while in MLL it was 66%. And for 1221, as we know that it cannot be detected by karyotype alone, so fish is mandatory to detect translocation 1221. So you can say that both entities are equally important to detect these cytogenetic abnormalities. So these are the overall results. Out of total cohort, there were total 5 patients who did not achieve remission morphologically. And out of 5, 2 were positive for BCR-ABL1, and 1 was with random structural abnormality, 1 was normal, and 1 case was with complex karyotype. So as we know that there is a huge data published on acute leukemia, its cytogenetic abnormalities, and its disease course from western part of the world, but from this part of the world, like from our centers, there is deficiency, particularly for advanced techniques, like we do not have MRD and PCRs widely available, so there is a scarcity of data in this regard. So these are some local studies. Here in this study, this is recently published from Lahore, and it is showing the prevalence of cytogenetic abnormalities in our patients in different hematological malignancies, and similar to our study, it is also showing hyperdiploidy most common. This is another study recently published, and they also studied the cytogenetic abnormalities with remission status. Again, the remission status was determined by morphological assessment of bone marrow. And they also gave the similar results, like the poor cytogenetic abnormalities showed lesser remission. This is the result of the same study, and in this study there were total 9 patients who could not achieve remission. This is a study published from Indus Hospital, I guess 2 to 3 years back, and in this study the induction status was determined by MRD, and its association was observed with fish, and MLL gene rearrangement showed the highest association with MRD positivity. This is another local study where MRD status was determined by flow cytometry, and in this study there was total 7% patients who were positive for MRD. This is the largest study I could find from local literature, and it was a little older, like published in 2015, and it was a multi-center study, but again the evaluation of remission was performed on morphology. So in conclusion, cytogenetic abnormalities did not show any significant correlation with clinical features other than leukocytosis, prophase response, and NCI risk. Hyperdiploidy was the most common abnormality in this cohort, and complex karyotype and translocation 922 are likely aberrations in cases with no remission. Our results also support that the use of fish with conventional cytogenetic distinctly improved the detection rate of recurrent cytogenetic abnormalities. Further reliable association can be determined by MRD assessment using flow cytometry or PCR. So, despite limitations, I think the study represents an appropriate application of available resources. The major limitation was morphological assessment, which is no longer a recommended way to determine the remission status of the patient. So, we should try to move on towards flow cytometry or PCR. So, these are the suggestions for future perspectives. Thank you.
Thank you so much, Dr. Neelam. Next up, we have Dr. Varkha Thakur. She is affiliated with National Institute of Blood Diseases and Bone Marrow Transplantation, Karachi. If we can have the timer on the screen, please.
Sorry?
No, to the technical.
Oh, sorry. Assalamu alaikum everyone. Today my topic for discussion would be coagulation abnormalities and risk assessment in APML, that is acute promyelocytic leukemia patient, and experience from resource constrained country. Small background information. What is actually APML? Acute myeloid leukemia is a clonal hematological disorder resulting from the maturation abnormalities of the myeloid lineage. Coming to the APML, APML is basically M3 subtype of AML according to the French-British PAP classification. It results from reciprocal translocation between chromosome 15 and 17 retinoic acid receptor alpha, that leading to the fusion gene formation, that is PML RARA, and that causes the clonal proliferation of the abnormal promyelocytes. APML was once considered to be the most malignant form of leukemia. However, treatment outcomes have improved tremendously with the advent of ATRA and ATO. One of the main features of APML is the existence of abnormality in the coagulation pathway, due to which around 60% of the cases present with a minor bleeding at the time of diagnosis. Prior to the availability of ATRA, early death due to hemorrhagic events was manifested in 10 to 30% of the patients. Despite the higher rates of cure that are described, coagulopathy remains to be the primary cause accountable for mortality and one of the reason for early morbidity in the course of disease. Hence, while treating APML patient, prompt ATA administration is paramount significance, which has been shown to improve the outcomes and revert the coagulopathy to a substantial extent. And in addition, platelet count should be kept above 20 to 30 into raise power 9 per liter via transfusion, and transfusion of FFPs and CP should be done to keep the fibrinogen level above 1 to 1.5 gram per liter. Okay, so objective. The sole focus, the main objective of the study was to assess the impact of coagulopathy in the risk stratified acute promyelocytic leukemia patients, irrespective of the bleeding manifestations. Okay, this was a cross-sectional study that was conducted in the National Institute of Blood Diseases and Bone Marrow Transplant from the November 2019 to December 2021. Approval from the institutional committee were taken prior to conducting the study, and the written consent were taken from the patient. Inclusion criteria: all the treatment naive patient of APML were included in the study, while patient other than APML and was patient that was on treatment were excluded from the study. The demographic and the clinical features, including age, gender, and the presence of bleeding events, were recorded. Sense score were performed for the risk stratification, and the diagnosis was done morphological by doing bone marrow biopsy, followed by confirmation by karyotyping, and then detection of PML RARA fusion via FISH on PCR. Laboratory test to assess the bleeding risk include complete blood count, prothrombin time, activated partial thromboplastin time, D-dimer, and the fibrinogen level. Sysmex 1000 analyzer were used to obtain the CBC, including platelet count. An automated lactex enhanced immunoassay method was used to assess the D-dimer levels, and fibrinogen levels were obtained using the Claus fibrinogen assay method. PT and APTT were performed on Stego and Sysmex CA15 through the immunoturbidimetric methods. Just a second. Okay, sorry. Okay, the main point in this was ANOVA was applied to observe the mean difference of laboratory paramount between the risk stratification groups, and multiple comparison were performed by applying the least significant difference LSD. Survival analysis was done using the Kaplan-Meier curve, and p-value that was less than 0.05 were considered to be statistically significant. So this was the result. Total of 85 ABML patients were registered in our institute during the study duration. Out of total, 62 patients were analyzed as per our study's inclusion criteria, that were treatment naive patient, and the mean age was found to be 32 years plus minus standard deviation 15.8 years, with the male predominance of out of 62 there was 34 patients were male, that is 55%. And these were the variables which we took during a study period. Age, mean age I have already described, that is 32 years and plus minus 15.8. Then respectively prothrombin time, that was normal 17.7 second plus minus 4.99, and then APTT, D-dimer, fibrinogen and hemoglobin levels, and then MCV, MCH, MCHC, and then most important were TLC and platelet count. As per the SENS score, 18 patients, that is 29% of the patients were found to have a low risk, and 22 patients, that is 35.4% were found to have a intermediate risk, and similarly 35.4 patients were at the high risk. History of bleeding was found in 71% of the patient, followed by fever noted among 45% of the patient. The most frequent bleeding symptoms in male were gum bleeding in 18 out of 34, and menorrhagia was noted in 6 out of 28 reproductive female patients. Raised PT, APTT and D-dimer were observed in 46, that is 74.2%, and 61.3% and 83.8% patient respectively, and low fibrinogen levels were noted in 26% of the patient. We try to establish basically the association of age and with the CBC parameter with the risk stratification. These were the all variables, and the significant value that was less than 0.05% was noted in the 3 variables, platelet count, retic count and total leukocyte count. When we compared the 2 risk groups, the significant value in platelet was 0.000% between the intermediate and low group, and then high and low group. Similarly, in total leukocyte count and retic count, when these groups low and high were compared, the p-value were significant, that is 0.001 and 0.002%. Okay, this was the main focus of our study, that we try to establish the association of coagulation parameter with the risk stratification and the bleeding status. That was the main objective of our study. These results show that patient can bleed irrespective of the normal coagulation parameters. As we can see in the result that prothrombin time normal were seen in patient according to the risk stratification. 8 patients in the low risk group, then 4 patients in intermediate, and then later on 4 patients in high risk. Out of the 16 patients, 12 patients were bleeder and irrespective of normal PT, and 4 patients were non-bleeder. Similarly, when coming to the APTT, D-dimer and fibrinogen, in spite of low fibrinogen level, patient were bleeder, and in spite of normal fibrinogen level, patient were bleeder. In spite of high fibrinogen, according to our results, we could establish this association, that our results were statistically non-significant. Like patient can bleed irrespective of their risk group, Either it's patient is in a high risk at the diagnosis according to the sense, it can be non-bleeder, or either with the normal coagulation profile patient can present with bleeding manifestations.
If you can please just hurry up, the time is up. To the conclusion.
Yeah, but I'm done. The association of risk stratification with bleeding status was evaluated with the coagulation parameters, and no statistically significant association was found. And this was the curve that showed significance of survival irrespective of low, intermediate and high risk group. There was no statistical significant value was found. P-value was 0.234. Like overall, among all the three categorized risk, 61 patient was survived and 39% patient expired. There was no significant value between risk stratification and the survival outcome. So this was the conclusion. The result of our study suggests that regardless of bleeding symptoms, coagulation parameters must be investigated at the time of diagnosis in patient with suspected acute promyelocytic leukemia, and in addition to ETRA, transfusion of fresh frozen plasma should be done. It has a clinical value, and adding to the algorithm of the treatment would be beneficial to the patient in the developing world where resources are already measured. Longitudinal studies with the large cohort in the future are needed in this context. Limitation, I haven't added this slide, but obviously main limitation was study where the sample size was too low because APML is not so common, and between in this 2 years duration only we could get 62% patient, and secondly it was a single center study due to reduced sample size. Multivariate analysis was not possible. So these were the limitation of my study.
Thank you, Dr. Varkha. Moving along, we have Dr. Mohammed Bilal Asghar from Armed Forces Institute of Pathology, Rawalpindi. Please welcome Dr. Mohammed Bilal Asghar.
Bismillahirrahmanirrahim. Worthy Chairperson, respectable seniors and my fellow colleagues, Assalamu alaikum. I am Dr. Mohammed Bilal Asghar from Armed Forces Institute of Pathology, and I will be presenting my study on bone marrow fibrosis grade being used as a useful prognostic marker in myeloproliferative neoplasms. This will be the sequence of my presentation. Myeloproliferative neoplasms are a group of clonal hematopoietic disorders characterized by overproduction of differentiated hematopoietic cells. Common diseases included prime myelofibrosis, polycythemia vera, and essential thrombocythemia. Bone marrow fibrosis is their central pathological feature and is a major diagnostic criteria according to WHO, and it is assessed through reticulin stain on bone marrow biopsies. Impaired megakaryocyte function, aberrant JAK-STAT signaling, inflammatory cytokines including transforming growth factor beta all have been implicated in the pathogenesis of bone marrow fibrosis. This slide shows the transformation of MPNs into other classes as well as acute leukemia, which leads to the poor overall survival. The objective of this study was to determine the prognostic value of bone marrow fibrosis grade predicting outcome of myeloproliferative neoplasms. Through this study, we wanted to see the correlation between different marrow fibrosis grades and MPNs, and to see whether higher fibrosis grade is associated with disease severity, transformation, and poor prognosis or not. This was a cross-section study carried out at Armed Forces Institute of Pathology over the period of 1 year. After approval from Institutional Review Board, non-probability convenient sampling was done. My total sample size was 114. MPNs including PV, ET, and MF were included. However, patients who lost to follow-up and MPNs other than aforementioned were excluded. Complete medical history and detailed physical examination was recorded on data sheet, and after aseptic measures and informed consent, bone marrow aspiration and refined biopsies were taken. After fixation in Zenker solution, tissue cutting, and processing, these to find biopsies, they were stained with HE and reticulin stain. In reticulin stain, silver oxide is precipitated on reticulin fibers in the presence of ammoniacal solution. Now, this slide is ready for microscopy. Under the microscope, the reticulin fibers, they stain black, the collagen fibers stain pink, and nuclei and cytoplasm stain shades of gray. Now, WHO has categorized this fibrosis scoring system into 4 categories. In MF0, there are scattered linear fibers with no intersections. In MF1, there is loose network of reticulin fibers with many intersections. MF2 has diffuse and dense increase in reticulin with extensive intersections and occasional collagen fibers. While osteosclerosis and increased collagen fibers, this is the hallmark of MF3. Coming on to results. Mean age was 51 years, and there were 63% males and 37% females in my study group. So, as we can see, the patients were divided according to WHO fibrosis grade, and most of the patients, they were falling in MF0 and MF1 grade. So, here is the age distribution curve, and we can see that most of the patients, they were falling in more than 50 years age group with male predominance. Similarly, here we can see that with the rising age, there was increase in myelofibrosis grade. However, p-value was not significant. In this slide, we can appreciate that that most of the cases from PV and ET, they were falling in the MF0 and MF1 grade, while higher fibrosis grades, they favored the diagnosis of prime myelofibrosis. JAK2V617F was the commonest mutation detected in my study group with percentage of 79%. So, coming on to the symptoms, the common symptoms were bleeding, spontaneous bruising, generalized weakness, fever, and abdominal discomfort. However, with increasing fibrosis grade, there was statistically significant rise in generalized weakness and abdominal discomfort. Similarly, these presenting complaints, they coincide with those our findings in the general physical examination, where pallor and hepatomegaly and splenomegaly was noted in the patients, and there was significant rise in pallor and splenomegaly with the rising fibrosis grade. In this chart, we can see there is a correlation between myelofibrosis grades and the mean of blood counts taken at the time of diagnosis. There was statistically significant rise in as the fibrosis grade became higher. There was HP, hematocrit platelets, they were severely affected. Similarly, in this slide, we can see that HP, hematocrit, and platelets, they are again affected with different MPNs. So, at this point, I would conclude that with the higher fibrosis grade, the patient is likely to present with abdominal discomfort, anemia, and with the rising fibrosis grade, there is a direct correlation with cytopenias. Coming on to the second part, these patients were followed for 1 year, and at 1 year, their peripheral blood counts were taken, and they were compared with those at the time of diagnosis. And it was observed that patients who were having higher fibrosis grade, they were less likely to respond to the recommended therapies, recommended guidelines. P-value was also significant in this case. Transformation was also recorded. 3% of the cases transformed to acute leukemia, while 14% of the cases showed progression to myelofibrosis. This slide, we will see, we can see that from MF0, most of the cases, they did not transform. However, from MF1 and MF2, most of the cases showed myelofibrotic progression, that is colored in blue color, while in MF3, acute leukemia was predominant seen. 2 cases transformed out of 17 cases. So, we can say that with increasing rising fibrosis grade, the risk of transformation to acute leukemia or myelofibrotic progression increases with the increasing marrow fibrosis grade. And hence, we can say that higher grade of bone marrow fibrosis at the time of presentation is associated with disease severity, transformation, and worse prognostic outcome. I would conclude that bone marrow fibrosis is a useful prognostic marker in predicting outcome of myeloproliferative neoplasms. Early diagnosis and timely management can limit the disease and help in patient rehabilitation towards a healthy life. I thank you all for your patient listening.
Thank you so much. Now for the last short talk, I would like to invite Dr. Kiran Amir. She's affiliated with Liaquat University of Medical and Health Sciences, Jamshoro.
Starting with the name of Allah, who is most merciful and beneficent. Assalamu alaikum to everyone. I am Dr. Kiran Amir from Liaquat University of Medical and Health Sciences, Jamshoro. And the topic of my presentation is additional cytogenetic abnormality in Philadelphia positive chronic myeloid leukemia. I have no conflict of interest to disclose. Chronic myeloid leukemia is a myeloproliferative disorder which is characterized by the presence of Philadelphia chromosome produced by reciprocal translocation of 922. According to the European Leukemia Net, According to the European Leukemia Net, recommendation suggests that the presence of additional cytogenetic abnormality at diagnosis represent an alarming sign which warrant careful monitoring of the patient. The appearance of additional cytogenetic abnormality during the course of therapy portend an adverse prognosis and signal overt disease progression and inferior survival. Most studies have focused on clonal evolution, which have become the routine protocol to assess the treatment response. Fewer studies have been reported the effect of additional cytogenetic abnormality prior to therapy. So the rationale of my study is to provide the data on additional cytogenetic abnormality in Philadelphia positive chronic myeloid leukemia, which will add in risk stratification of patient. The objective of this study is to determine the various additional cytogenetic abnormalities in Philadelphia positive CML by conventional cytogenetic. The study was performed at Diagnostic Research Lab of Liaquat University of Medical and Health Sciences. This study was descriptive cross-sectional study. And this study was performed from January 2017 to September 2021, and total sample size was 78. All the sample selection criteria was there. The patient of both genders diagnosed with CML on the basis of morphology and the cytogenetic analysis were included in the study, while the patient on hydroxyurea therapy, interferon or TKI treatment were excluded from the study. After taking the written and informed consent, history was taken and the physical examination was performed. After the aseptic measured, the laboratory samples were taken for the CBC and peripheral film were reviewed. Bone marrow biopsy was performed, and on the morphological examination, the CML was diagnosed. Then this conventional cytogenetic was performed to detect the Philadelphia chromosome, and the BCR-ABL was performed by PCR. These are the different steps by which the cytogenetic were performed. Now the results. In the total 78 diagnosed cases of CML, the mean age of in my patients was 36 years, and the range is 14 years to 70 years. According to the gender distribution, 52.5% were female, while 37 were male, and the frequency was 47.4%. The frequency of additional cytogenetic abnormality in 78 patients of CML was found 13% cases. The additional cytogenetic were found in 13% of the cases, and the total patient was 10. The double Philadelphia were present in 20% of cases, while the variant Philadelphia were found in 30% of the cases, and other cytogenetic, additional cytogenetic abnormalities were found in 50% of the cases. This is the different additional cytogenetic abnormalities according to the patient-wise in 10 patients. This table shows the frequency of additional cytogenetic abnormality according to the phases of the CML. 8.2% cases of chronic additional cytogenetic abnormality was found in the chronic phase, while 75% were in the accelerated phase shown the additional cytogenetic abnormality. And one patient were diagnosed in the blast crisis phase, and this one patient showed the additional cytogenetic abnormality. Now the discussion. One of the study done by the Sunila et al. And in this study, the total number of patients were 498. The mean age of the patient were the 39 years, and the range is 18 to 74. And the frequency of additional cytogenetic abnormality in that study was 4.9%. The most common additional cytogenetic abnormality was found in the Sunila et al. Study was loss of Y chromosome. While in the current study, the frequency of additional cytogenetic abnormality is 13%, which is quite higher. This may be due to the smaller sample size. This study unveiled that the fact that additional cytogenetic abnormality are frequent in CML patient, but their frequency and distribution varies between the different clinical stages of chronic myeloid leukemia. The strength of my study is that it is one of the few local studies addressing the issue. May act as a database in the future work in this region. The limitation of this study is the smaller sample size. It is a single center study, and long-term follow-up was not performed to assess the prognosis of Philadelphia positive CML individually and with the additional cytogenetic abnormality. Recommendation is that the similar research should be carried out on a larger samples of the participants reflecting the long-term follow-up to assess the prognosis of Philadelphia positive CML individually and with the additional cytogenetic abnormality mutation. Comparison of the additional cytogenetic aberration in the Philadelphia positive CML patient to those with the Philadelphia negative CML should be performed. Thank you so much.
Thank you so much. Now with this, we end our short talk session. The winners for both oral and poster presentations will be announced in tomorrow's session. Now may I please invite Dr. Natasha Bahadur Ali to present shields to our respected chair and co-chair. All right.
right statistical tools in order to come up to the correct OR ratio and hazards ratio. And in almost all the presentations, when you are saying that this is of importance, for example, the biomarkers in COVID are important, etc., you tend to forget the confounders which are there in the study. For example, the age, gender for the D-dimer, and for the various other comorbidities that are present. So you have to use the right statistical tool in order to come to a particular conclusion. And when the size of the studies is small, usually you tend to lose the larger picture, and the results are not that much, they are not statistically, they are not important because the sample size is small. So this is just my one suggestion, that whenever you are doing a study, please involve the statistician from your hospital, university, or you can approach other universities to help you. And there may be other people who can help you in finding out, in order to do the correct analysis, and because that may affect the results and conclusion of your study. So this is just a word of advice for the younger investigators.
Thank you, Dr. Bushra. Please welcome Dr. Natasha. Dr. Salman Adil, please come and accept your shield. Dr. Usman Sheikh, please come on stage and accept your shield. Thank you. Thank you, Dr. Natasha. Thank you. Much to all the participants for your valuable time and being present here, and thank you to all the speakers and also the panelists. Thank you so much. There is also a poster exhibition, so please you can all go ahead and see all the posters of our residents and the technologists. And there is a workshop tomorrow from 9 to 1 on coagulation. So please attend that workshop. Thank you.